wonderful to see everybody here in person. Before we start, I'd like us to take a moment to remember Holocaust Memorial Day tomorrow and the many millions who were and are being persecuted and murdered because of prejudice and discrimination. It's a time for us to reflect, to remember them, and to ensure we abide by our own values personally and by the values as an organisation. Thank you. We have a very full agenda, as always, so I'd be grateful if all members kept their questions and answers concise, so we can give proper consideration to all the important matters before us today. And I'd also like to take this opportunity to thank the executives and directors for the timely submission and the quality of the papers that we are considering here today. So I'll go straight to the agenda. Apologies.
Yes, Chair, we've got apologies from Mr Bernard Davis and Dr Mohammed Nazimi, and we have also got Paul Newman and one of our independent members on Zoom, and Anne Began also on Zoom from Audit Wales, Chair.
Thank you, diolch. And any declarations of interest?
Whisk.
Okay, thanks, Chantel.
We've also got two declarations of interest, Chair. Anne is obviously a member of the RCN and with the industrial action will not be permitted to partake in any of those conversations, and Mandy also as our nurse director, but as the accountable director on the board will still need to give her opinion and advice to the board.
Thank you. Thanks, Anna. Thanks, Mandy, and thanks, Chantel. Okay, if we now go to the minutes of the public meeting held on the 24th of November, are there any inaccuracies that people would like to bring to our attention? Board happy to approve the minutes? Thank you. Are there any matters arising? We go straight to the matters arising. Anna?
Can I give an update, Chair, on table of action PM 22-200 around the meeting between the chairs and executive leads for the three committees most closely linked to targeted intervention and enhanced monitoring. Just to report to the board that we did indeed have an initial meeting. I think we all felt that was a productive conversation. We identified two specific areas where we want to test out some greater cross-collaboration across committees. One around the new requirements around duty of quality and candour, and another around the planning maturity matrix that we are moving forward in our organisation. And the intention is that we will now continue that piece of work and provide a fuller report to the board in due course.
Thank you, Anna. Any other matters arising? Could I ask a question in relation to PM 22-205, I assume it's on the page before, and it's in relation to all cancer patients having an allocated nurse. Mandy, I wonder if you could give us any idea about the numbers of people who may be still waiting, or the scale really of the challenge.
So in terms of the number, are you referring, Chair, to the number of patients waiting in terms of cancer treatment or the allocation of a
nurse?
So the expectation is that once the diagnosis has been made that the patient will have a named key worker. I've picked this up with the lead nurse directly to try and ensure that we don't have any instances going forward where patients are unclear about their point of contact. Unfortunately, I have dealt with a further complaint this week, and I will be following it up again because the importance of having that key worker to be able to coordinate and act as that single point of contact is something that we need to continue to be committed to providing. So whilst I've had some assurance, I need to go back and further investigate, because I personally have some questions about the level of consistency of that allocation.
I wonder if it would be, if the data and your concerns and assurance could go to the Quality and Safety Committee.
Yes, absolutely. I believe that we've got cancer services down as an agenda item as part of the work programme.
Okay, thank you. And if I could also raise a question on the first action, PM 22-195, in relation to the discharges of people who are in our organisation. And I just wondered whether we should have a separate report coming to board or a committee on all the initiatives that are being undertaken and the impact or not of those initiatives and the scale of the problem, because it seems to be one of the key factors which is causing a lot of problems at the front door and throughout the system.
Yeah, I'm sure Jill and I would be happy to pull together a more detailed paper on those issues and everything we're doing to try and mitigate them. We've provided a bit of an update within our operational report today, which gives a sort of position for the board. But yeah, we can do something more detailed.
Okay, thank you. Thank you. So we go on to...
Chair, sorry, before we move on,
Yeah.
if anybody's got any mobile phones on the table, can you just move them or turn them off, because it just causes an interference with the live stream. Thank you.
Thanks,
Thank
Chair.
you, Chair.
Thank you. Okay, next item on the agenda is my report. I'll take it as read. I just draw your attention to a couple of things there. I think the main one is, as we all know, through personal experience to professional experience and through the media, that we, along with the whole of the NHS in the UK in social care, are experiencing the most unprecedented pressures that we have experienced. And this is causing moral harm to some of our own staff, and regrettably, in some circumstances, the care for patients isn't what we would like it to be. And I'm assured, as is everybody else here, that we are doing, and our staff are doing, absolutely everything possible to plan for and respond. So I'd just like to take the opportunity to thank everyone in our University Health Board for the dedication and service continuing in these very difficult times. As you'll see from my report, there's a lot of good news in there and an awful lot of recognition and awards given for our incredibly able staff who are still shining in these difficult times. And I'd just like to briefly draw our attention to the fact that our senior chaplain, Irel Howells, got the British Empire Medal in the King's Honours List, which is wonderful, an unsung hero. And 3 of our senior leaders, I'd like to congratulate them, were awarded honorary professorships by Aberystwyth University. So that's Dr. Leighton Phillips, Hugh Thomas, who's here today, Professor Thomas, if I may say, and Dr. Helen Munro. And then the rest of my report, as you can see, sets out all the success and awards that our staff have gained since the last meeting. So I'll open up to questions. Ewan.
Thank you, Chair. As you say, we're in kind of very challenging times. But I think in terms of our staff, just to note, yesterday I had the great privilege of attending Glangwili on your behalf to present some long service awards to colleagues from audiology, radiography and physiotherapy, who had each, in those respective departments, given 42, 44 and 45 years worth of service to the NHS here in Wales. And whilst we're in these challenging times, all the staff that I spoke to yesterday said it was so important to have that recognition and for us as a board to recognise the impact that they make in terms of their compassion and their commitment as well. So I think in these kind of challenging times, it was nice to have that ray of light yesterday.
Yeah, thank you. Any other questions on my report? No. Is the board happy to accept the recommendation? Thank you very much. We now go over to the report of the Chief Executive.
Yeah, thank you, Chair. I'll be relatively brief because I think the report is self-explanatory, but you'll see in my report that we've had a number of fairly key meetings with Welsh Government since the last time we met, the first of which was our first formal quarterly targeted intervention meeting, which was chaired by the Director General. You'll see some detail in there about the nature of the discussion. I think in summary, there was real recognition of the actions and the progress that we've taken so far in relation to our escalated status. And they reconfirmed their intention, I think, a number of times to try and ensure that this was a shorter process as possible to get us into de-escalation. The second key meeting was the Joint Executive Team meeting, which is a wider meeting of the Welsh Government Health and Social Services Group, again chaired by the Director General with the whole executive team. Again, very positive about the the achievements that we've made, particularly in planned care, which I will not steal the thunder of the Director of Operations later in the agenda. And they appreciate it, and I think have a real understanding of the challenges that we face and the actions that we're taking, especially in relation to our urgent emergency care system and our finances. They also recognise the really good work going on in workforce, our organisational development, our governance, and in particular things like our value-based healthcare, which it does feel like we are standing out across Wales. Other elements of the report, which again I won't go into detail, but just to highlight, it is great to have our gold revaluation for our corporate health standards. But also, probably to end on a slight negative, just the enormous challenges arising from the industrial action. I've covered some issues in there, but of course that's something which is building momentum now into the new year. And I'm very proud of the way in which our staff, the team around the table here, have rallied in order to deal with that in the very best way possible, both to look after our staff and to look after our patients. Happy to take any questions.
Thanks, Steve. Questions? Judith?
Yeah, just one question, and thank you for the report, Steve. It's on the final paragraph under the industrial action on page 4, and going on to the recommendation, we're asked to ratify a decision in relation to industrial action on those 2 dates in December. Is it the intention that those steps are taken or have been taken in the action that's occurred since then, but in any future days which are coming on?
Yeah, I think it's a good point. So I think we'll take each industrial action event as a separate sort of planning issue. It's likely we'll try and do take the same approach, which is to minimise the impact on our services and the number of cancellations. But it is likely that we're going to need to take a similar approach for future ones. My plan would be, if the board is happy, and I probably should have clarified this in the paper actually, that the tactical group continue to make those decisions in the moment, because it is a very fluid situation, and every day of industrial action can be quite different from previous ones depending on the staff who are on and the interactions, but that we always bring that back for full ratification to board after the event.
Okay.
Chantal?
I just wanted to ask around the impact, because we already have a waiting list as a result of COVID, and then now that we are having those different strike days and we're putting measures into place in order to manage existing patients. So how will that now impact on the waiting lists in terms of the future arrangements?
Yes, I mean, the Director of Operations might want to come in specifically, but I think the first thing to say is, as the board is aware, we negotiate a set of derogations, so we try and limit the areas in which those impacts are as far as possible, whilst recognising the right to strike and ensuring that staff have the opportunity to do that. But of course, every one of these does have a cumulative impact in some part of our service. I don't know, Andrew, I think you've got the latest numbers from the previous industrial action, which will probably give us an indication. Yeah,
of course, Steve. So in terms of the first 2 days of the industrial action, which are the 2 initial Royal College Nursing strike days, we lost around 1,000 outpatient appointments over the course of those 2 days. The industrial action since then has been more centred around GMB and Unite, which has impacted more on our ambulance service in Wales, and therefore it's been around how we've redeployed resources within the system to help add more resilience to our front door areas to facilitate the timely handover of patients from ambulances, given that they're running at a reduced capacity on their strike days, to just make sure we maintain flow. So in doing that, we've really minimised the impact on the number of patients that have been affected from an outpatient or operating perspective. I think what I probably, a bit like Steve was saying in terms of the future days, and what I probably need to flag is that the dates on the 6th and 7th of February, where there's a number of unions taking industrial action over a 48-hour period at the same time, it is likely that our response will have to be much more, or the service we provide on those days is going to look a lot more like it might do on a Christmas day or a bank holiday. So it probably will have a greater impact on our elective capacity over the course of that 48 hours. At the moment, obviously, the impact of those days so far has obviously delayed our progress in terms of some of the improvement around access to services. It didn't, as we'll talk about later, it didn't hinder us getting to where we said we would get to by the end of December on outpatients, for example. There is obviously the risk as more industrial action happens over the next 2 or 3 months that it will start to have a greater impact on access to all of our services, and particularly our ambitions around our inpatient and our stage 4 treatment treatments before the end of March and going into next year. So we're monitoring that. We're monitoring that closely. So it's having an impact that I'm very mindful that it does have an impact. If it was around assurance around where we would be against the plans we gave to the board and delivery terms, then we're still on track with the plans we gave in terms of activity, because we'd managed to get ahead a little bit in terms of our actions.
Thanks, Andrew. Thanks, Chantel. How are we communicating with patients in relation to cancellations? Do we have a specific plan, or are we using current reserves?
We phone them all. Because of the time frames we're operating in, we endeavour to make contact with and speak to every patient that we need to rearrange an appointment for, and try and rearrange it almost at that point, or if not within a week or two of the initial phone call. Obviously, we can't always make contact by telephone with everyone, but we'll follow that up more than once, and with through the post and other contact details we've got to try and make sure we reach everyone. Thanks. We're fairly confident from those first 2 days we made contact with the vast majority. We don't think there were many that we didn't manage to get hold of.
Thanks, Andrew. That's really good to hear. Mandy?
Yes, in addition to that, obviously, through our awareness team, we're also making sure that we have got communications being issued out through various media platforms, our social media platform in particular, to advise patients and their families about what to expect. The one thing I would add is that I think whilst we recognise the impact on the day, we can't forget the amount of work that our operational teams are having to put into the make-safes in the days leading up to the action, and the impact that that may be having on the smooth running and delivery of services. So I just think I need to flag that. The other thing I would like to say is that we are very aware of how we capture any incidents, any potential harm that may be happening, and that is then feeding into our incident reporting process. As I sit here today, I can't tell you that I have any incidents to report, but that is something that we are keeping a very live eye on.
Thanks, Mandy. Ali?
Mandy's actually said most of what I was going to add, but just to give some assurance as well that we have a very active industrial action planning group, which is meeting on a daily basis at the moment to make sure that we're planning ahead, we're mitigating as much as possible all of the risks, and when we get to the risk report later, which was only updated 2 weeks ago, this is so fluid that it's actually very out of date now. So just to provide some assurance that we've got a very active team working on it.
Thank you. Thank you for all the efforts. It has given the board assurance what you're doing everything possible to mitigate the impact on patients. I think Paul wants to come in and ask a question. Yeah.
Thank you, Chair. It wasn't so much a question as an observation, really, in relation to targeted intervention. I've been sitting in as an observer of the targeted intervention working group, and just to give some assurance that there's clearly been an enormous amount of effort put in by the executive team to address the issues which Welsh Government had raised, and there's a very clear methodology to the way that those meetings have been held, and a very clear action log and trail being kept of the activities which have been undertaken and the reason why any actions which have been completed have been closed off.
Thanks, Paul. That's really helpful for the board with your assurance. I also sit in on one of the groups as well as an observer, and I concur with what you've just said. My only concern is the risk of possibly over-reporting and over meetings when the executive have to attend other Welsh Government meetings as well as targeted intervention, and I hope that these can be streamlined going forward, in order to give the executive time to do their other roles as well. Any other questions? Okay, the board's happy to accept the recommendation, and thank you, Steve, for your report. If we now go on to the report of the Audit and Risk Assurance Committee, Paul, that's you.
Yeah, thank you, Chair. It's the report from the meeting which was held on the 13th of December. The report hopefully speaks for itself. You'll see that there are a few things at the end of the report need to just draw to the board's attention or require approval. First of all, the risk management strategy, which was considered and requires endorsement from the board. The change to the scheme of delegation and the position with regard to the structured assessment. Obviously, we're about to talk about that because it's on the agenda. But because of timing, normally we would have had the management response at the audit committee. Because of the timing of both the meeting and the receipt of the report, it wasn't possible to do that. We'll be having the management response at the next meeting of ARAC, and we'll be able to scrutinise that management response at that meeting.
Thank you, Paul. Are there any questions or comments? The board happy to accept the recommendations of the committee to endorse the risk management strategy and agree the recommendation for approval, changes to the scheme of delegation? Yep. Okay, thank you. And thanks, Paul. And that leads us to the risk management strategy.
Yes, Chair, I think we've covered it. Just to add to Paul what the board said, I mean, thank you for endorsing it. It has been out to full consultation within the organisation and also with the board. So if the board's happy to approve, we'll now enact that, Chair.
Yeah, thank you, Jeb. The board's approved. We then go on to the Audit Wales Annual Audit Report 2022, and I'm delighted to welcome Anne Began to our meeting.
Thank you, Chair. Good morning, everyone. So I'd just like to say thank you just for giving us the time today to go through structured assessment and the annual audit report. I'm going to propose, if it's all right with you, Chair, just to focus on structured assessment first. You'll see from the annual audit report it covers structured assessment, so I'll just pull out the key messages on structured assessment, if that's okay. A couple of things just to highlight on structured assessment. So those around the table obviously will be familiar with our structured assessment work. I think the key thing to highlight is we've taken our structured assessment back to our core structured assessment. So for the last couple of years, it's been very much through the lens of COVID. But for the work in 2022, it was kind of back to the core areas, focusing on strategic planning, corporate governance, the financial management and use of resources. Overall, it's a positive picture. I think we generally are positive from a structured assessment perspective. Particularly, there's lots of areas in there that are positive, but particularly around the governance arrangements. But it's important, obviously, that we need to reflect some of the challenges that you as the health board are facing, particularly around the financial position and the consequences of what that means for you to be able to get an approvable IMTP. You'll see from the report there are a number of recommendations. A couple of these do relate to planning and finance, but there are also a couple of areas in there that, if you look in the report, you'll see reference, particularly around the organisational structure and the need just to kind of streamline some of the performance arrangements wrapped around the operational teams. I don't propose going into the report in any more detail, so I'm happy to take any questions, and then I'll just touch upon the annual audit report.
Thank you, Anne. Any questions?
Yeah, thank you, Chair. So just to add, really, just to give some assurance, we have reviewed the report in detail with yourself, the Chief Executive, the Director of Finance and the Director of Planning, and myself. So that obviously is culminated in the report you've seen today. We've already produced the management response, which we will share with Anne today, which has now been collated, and we'll take that through the audit committee in February, Chair. And just wanted personal thanks really to Anne and the team for the way they undertook the audit this year, because it's still been quite challenging. And I think we felt the report really did reflect where the organisation was, Chair.
Many thanks, Jo, and many thanks, Anne. Any other questions? Hugh?
Chair, I'd just like to echo the thanks that the Board Secretary gave there, in particular across the breadth and depth of services we get from Audit Wales, and particularly to Claire James, who is with us and leading the financial audit this year, and of course is moving on into other areas in Audit Wales and will be replaced by Anthony Veal for the coming year. And Claire was really helpful in supporting us in a piece of work we've done within the finance department to reduce the risk of management override, which is one of the risks that Audit Wales always flag up as part of a routine risk assessment across every organisation. But Claire was instrumental in supporting us in thinking about how we best respond to that risk. And we're doing some work on that, and that will come back over the coming year.
Thank you, Hugh. Any other comments or questions? Well, on behalf of the whole board, we'd like to reiterate what Hugh and Joe has said, Anne. So thank you for the report. So we go on to the annual report now.
Yep, so in terms of the annual audit report, obviously, again, you've got the report in your pack. I won't echo what I've already said in terms of structured assessment, and obviously the kind of the other half of the annual audit report talks about the accounts last year, and that obviously just picks up a couple of things, and Hugh's obviously mentioned the work that Claire did, so happy to take any questions on the annual audit report.
Thank you. Any questions?
No, again, just for assurance, Chair, we have been through the report in detail prior to it being presented to board today.
Thank you. I think we had an AI question that has been terminated. But thank you very much, Anne. And thanks for all the quality advice that you give us and draw to our attention. Diolch yn fawr.
Thank you, Chair. And can I just echo back, just to thank you as a health board, the support that you give to us. And I'll feed those comments back to Claire personally. So thank you very much.
Thank you. Take care.
Thanks.
So the next item on the agenda, 2.7, is report of the Quality, Safety and Experience Committee. So over to you, Anna.
Thank you, Chair. So the report stands. The Executive Lead and I made a decision that the December meeting should proactively incorporate all 5 issues raised through enhanced monitoring to ensure that we were bang up to date on matters that we have been considering during the course of the year. So you will see all of those items covered in this report without wishing to overshadow all sorts of other business that the committee is already engaged with. So we are trying to strike that balance appropriately. We have a substantive item on the agenda later on around critical care, so just signpost towards that. And I note that in the operational report later there is an update around the MIU at Prince Philip, so I suggest that we hold questions on that until we get to that point, unless you want to take that now, Chair.
No, that's
Otherwise,
fine.
happy to take any questions.
Thank you. Any questions at all? Okay, thank you, and we will discuss the MIU when we get to Andrew's report. Thank you, Anna. Next item on the agenda is the annual plan update. Lee.
Thank you, Chair. Board members are obviously very familiar with the requirement for us to produce integrated medium-term plan each year. As you know, we currently don't have an approved plan for this year, and of course we have been escalated target intervention, as has been mentioned, largely due to our deteriorating financial position since the pandemic. We have received the most recent funding allocation letter from Welsh Government since the last board meeting, and who will take us shortly through the key points and the implications of that from a financial outlook for next year. Also, since the last board, Welsh Government has issued us with its planning framework, including the Ministry's priorities for next year, which obviously we'll be looking to feature heavily in the plan that we're developing. And it has been confirmed the plans are required to be submitted by the 31st of March, so that's the timeline that we're working to. Work has progressed, as the paper notes, across looking at the revised set of planning objectives, which we've talked about at board seminar, and we've got a session dedicated next week to the plan with another board seminar where we'll be taking board members through that in some more detail as to what we're proposing there. And we as an executive team went through that again in a lot of detail yesterday. Just a final point then before I hand over to Hugh. We have agreed as an executive team that we will not be in a position to submit an integrated medium-term plan for the next 3 years because we're not in a position to submit a financially balanced plan over the 3 years, and therefore we will instead need to be submitting an annual plan and an accountable officer letter to Welsh Government. So as part of the paper, we're requesting board support for us doing that following the board meeting today.
Thanks, Lee. And if I hand over to Hugh.
Chair, thank you. Move the mic over. Thank you. Chair, this is probably the most challenging financial settlement that has been in place since the devolution began. It is an incredibly challenging financial backdrop that we're facing, and a challenge for us locally in interpreting the impact of that on our local communities and trying to protect our local communities to best effect against those issues. I think it's fair to say that we are now at the point where we've had two step changes. So we've had a step change in terms of the demand on our services that we've experienced this year, and that step change has resulted in our underlying deficit going out from the 25 million that we'll all be familiar with to broadly 80 million that we're looking at going into next year. Now, the construction of that position is largely related to the issues we're facing with flow through the system that we've rehearsed before, and the challenges in recruiting staff, and therefore that capacity being taken up and supported by agency staff. So that's the fundamental driver to the 80 million that we're looking at. The next step change as we go into next year is fundamentally one of the economic impacts that we're facing, the impact of Brexit, the impact of the war in Ukraine, the inflationary pressures coming through that, coming through and affecting our system locally. The net impact of that with the allocation that we're receiving next year gives us a new challenge of about 30 million, 29.1 billion. So that's the new step change that we're facing going into next year. In many ways, it's an external challenge that we're facing locally, and the funding hasn't been able to keep pace with that. Funding from Westminster hasn't been able to keep pace with that into Wales. So that's the key driver that I would say going in from this year, where we've been, to a large extent, those issues have been mitigated by schemes that have been put in place across the UK in terms of energy protection scheme, and locally through the work that we've been doing across with other colleagues through shared services. But we are now fully exposed to those issues going into next year. There may well be other schemes that government put in place at a UK level as we go into next year, but at this point in time, excuse me, we don't have that certainty. So those are the two step changes that I wanted to make sure the board were clear on. Of course, the additive impact of that takes us into a deficit space which exceeds 100 million. And that's certainly the first time that we've been in that position. And what I would say is across Wales, all health boards are facing a similar scale of challenge that we're looking at going into next year. The challenge for us is how can we then mitigate some of that impact, and therefore the focus is on the savings that we can put in the system, the identification and the delivery of opportunities that we know we have, but also how do we identify elements of waste in the system, elements of frustration for all of our staff, and put in place schemes that begin to offset those drivers of waste that will be similar to some of the drivers of harm that we're seeing, so that we align around a strategy that addresses not just our financial challenges, but the core that's driving those financial challenges, which are the operational drivers and the clinical drivers that we see across the organisation. So that's the big focus. The numbers that we're seeing are moving around a little bit at this stage. I do appreciate that the numbers I've quoted there may be somewhat different to what we've got in the paper. That's just because we're in that modelling period now where numbers quite naturally bob around. It's a particular challenge this year because inflation is so volatile. So I don't think I've been in a reporting cycle or in a planning cycle where we are facing such big variations from almost one day to the next, because the multiplying impact of inflation is so significant for us. So this will be a very risky period going into, and having hard numbers is going to be a challenge for us. So I would ask the board to kind of bear with me while we work through what will need to be a risk reporting framework that captures some of those significant risks that we are then managing.
Thanks, Hugh. That's a really clear summary of what we and the rest of the NHS in Wales is facing at the moment. Do you think all of those factors are also in the context of the unprecedented, you know, challenges to our staff. I know you mentioned demand, but this ongoing demand now we've had for 3 years post-COVID, or we're still, you know, call it an endemic now, not a pandemic. We're asking them to make savings, and it's identified in this report there is a possible 77 million opportunities there, but the confidence isn't there that that would be delivered. And I know you said we can't have figures because it's changing all the time, but in your opinion, and you aren't the deliverer of this, it's the whole organisation and through every executive's portfolio, how confident are you of a percentage of that 77 million being delivered, and what percentage do you think is a reasonable one? And I'm wary that by giving that answer, we might lower expectations, and we need to aim high. But as a board, we also need to know the reality of what we are asking in our organisation in the context of everything that you've just described.
Chair, and it's incumbent on us to provide data and information and figures. So I do take that point on board. The first starting point, I think, is that we are looking at a deficit that is well in excess of the funding that government is able to approve. And therefore, the responsibility for us as a board is to the totality of that deficit and to the totality of the spend that we incur, because we are looking at spending well in excess of what would breach a regularity opinion from an audit perspective. So you know, that is in itself a particularly serious place for us to be, and a sobering place for us to be as a community. I think there are a number of I guess, micro, meso, macro kind of categorizations of what we can do. A lot of what we're saying in that 77 million opportunity that we have is essentially an expression of expenditure that we have currently in the system that we would not want to incur in that way. There is an agency premium in there. We would not want to incur that agency premium. There are beds that are being consumed by people who would be better cared for in other settings. We would not want to be spending that. So that 77 million is, if you like, all to go at. But the reality is that we are facing those pressures in terms of demand. So the delivery is going to be far less than that. We went through this yesterday as an executive, and you know, while we've got at the moment an assumption that 24 million would be a broad requirement of savings, that may change as we model that through. The reality is that as a health system, we've not delivered anything in excess of about 10, 12 million pre-COVID when we were in turnaround. So the challenge is, how do we go from what may be a normal delivery period into that very transformational space? So I think that is a fundamental issue for us. At this point in time, we don't have trajectories that provide us with assurance that we would get anywhere near that 24 million. I'd say it's much closer to half of that in terms of the information that's coming through at this point in time, but we need to work through and validate that. So that of that 77 million, I think a large chunk of that is work that we need to be working on locally, either at a directorate level, health board level, or regional level. Then there's another chunk, and the new 30 million, if you like. I think this is a challenge that is for me and colleagues in their peer groups to be thinking about nationally. And I'm not necessarily saying this is a Welsh Government issue, but it's something that we do need to address at a national level. And there'll be some of that we can do within our national peer groups, and there'll be some of this that will need government support to address, given they are externally imposed inflationary pressures that we're seeing and are being expressed. So I appreciate that's not a particularly detailed answer. We'll need to work through this, and we'll have the opportunity through the board seminar to explore that in more detail. But I wanted to kind of give a broad expression of the kind of micro work that we need to do within directorates, the work we need to do as a health board, and then the national work at a macro level.
Thank you. In view of the enormity of the challenge and the gravity across the whole of Wales, in governance terms, I know we've got our Sustainable Resources Committee, which has a massive agenda. I'm just wondering at board level, should we give more time to this challenge in a board meeting as well as the seminar? The seminars are wonderful because it's single issues generally, gives us hours to deliberate, come together. But I think it may assist if we have more focus on this at board level for our public for assurance, for the Welsh Government for assurance, and board for assurance.
Yeah, and I think that's probably what was in our minds without maybe being explicit about it, because this is such a significant issue for us. Just I wanted to say a couple of things, if I may, just on it. I mean, it is utterly daunting. I don't think I've ever seen quite such a large number that we're facing. I guess the first thing to say on that is our approach, and I think this is to recognise where staff are, particularly our operational staff at the moment, but also how we energise people around this agenda.
Yeah.
We're going to, by and large, avoid simple percentage cost improvement programmes, which then get rolled out across the organisation. Is probably part of the tradition of the NHS how they are maybe missing its targets, because that's all about how you salami slice bits off services, and it never quite gets to where you need to. So the opportunities framework is the key part of that, as the Director of Finance said, 77 million in there. Those are all being worked through at executive level, very much held at executive level, and we talked that through in some detail last night. There's going to be some discussions we need to have both in seminar with board, and then I think through the year on how some of those opportunities get played out, because we're going to face some. It's easy to say, and it's sort of, it seems to be the mantra at the moment across the NHS, but some very difficult decisions for us. I think the nature of those decisions are going to be if we can reconfigure our urgent and emergency care system in the way that we're imagining, that will create a choice for us about, do you cash out that benefit, or do we stop having ambulances, stop having people cohorted in ED, stop having other sort of suboptimal services. Now, I'm guessing we'll be somewhere in the mix that it won't be one thing or the other, but given the financial situation, it's going to be very hard to simply say we're going to make the performance better in the system. I mean, that may be what we want to do, but I think that needs to be a very conscious board, public level decision about where we strike those sorts of balances. The second piece of work which Hugh is coordinating is much more bottom-up with our directorates around, focused on opportunities where there may be waste or duplication, and getting their ideas about how they can take that out, and that would create another number sort of from the bottom up of the organisation. And then the third part, which we'll talk about in seminar, is based on the work we did late in 2022 to establish some principles. Actually, if we had to, where would we go first to cut things, which may not be services, they may be other things, and what would the principles upon that be, and where would we go, and where would we definitely not go? We need to bring that firstly all to seminar so that we can understand that ourselves. But again, I think to pick up your point, when we start to make those decisions, we need to make them publicly so that everybody is fully aware of them. Yeah. I think in overall terms, whilst we need to make sure we absolutely maximise what we can do in the next financial year, we need to ensure that that sets us on a firm foundation for a long-term financial recovery. So not doing very short-term things that will actually put us on the wrong path. Yeah. And there's a lot of really positive work going on in the background, which I think will help us describe a long-term roadmap which gets this organisation to financial balance, as bleak as it feels at the moment. Yeah,
yeah. Thank you for that, Steve. Did you want to come in, Hugh?
Chair, I am conscious that in going into this space, we are going to be talking about things like productivity, things like cost improvement plans, and choices that will be difficult. But there are clearly people at the end of the services we provide, and there are staff at the end of the language that we use. And I'm very clear that when we talk about issues like productivity, it is not about people working harder. People cannot work harder. Yeah. It is about providing the tools to our teams and our systems to enable the system to be more effective. And digital is a part of that, and I'll declare my interest in that clearly. But digital is a key part of the answer for us. Scaling up the work that we're doing, which has been really embraced by the organisation in terms of improving together, is another part of the answer. Scaling up and pushing on the work that we'll be doing on measuring patient outcomes, measuring the impact we're having, thinking about our pathways, our communities and our services through a value-based healthcare lens is another part of the answer. And then clearly service transformation is another part of the answer. These are all things that will make the system work better, enable our staff to be less frustrated, address the waste, the harm, the variation we have across our system, and provide a financial benefit to us. So there is a confluence of all of our agendas here. This isn't about finance versus performance or finance versus safety. We have to make sure that we pull our agendas together to be coherent and be side by side as the challenge for us is going to be intense.
Yeah, thank you. As chair, I find this assuring because it's also based on our values. And we face the challenge together, and we serve our staff and our people as well we can based on those values. So at the seminar, if we could also discuss about the best way to have these discussions at board level as well. Sure. I'd really welcome that. Deli.
Thank you. Pardon me. Thank you, Chair. It's just, for me, just a question about plain language and how we really interact with our staff and our public and our communities to really understand what the scale of the challenge is for us in our communities. And also thinking about working in partnership. I think you mentioned nationally, but did you mean nationally as an NHS? Or are we bringing in our local authority and our education partners, because we can't do it on our own? So that's the question I have to ask. Maybe that will come out within our board seminars, but I think it's really important that we really choose the language that our public and our communities understand, because it's very scary for them.
Thanks, Deli.
Chair, absolutely. There is a health board, regional, but also a regional conversation with our local authority partners, our third sector partners, all of whom are facing very similar challenges. And there is a danger that we all, I think we have learned as a health board, particularly through value-based healthcare, actually, if I turn to medical director, we've learned through the health board about the importance of taking decisions that don't affect one bit in isolation and think about the broader system. There's more to do on that in the regional space, especially as choices get taken in other areas that will have consequential impacts on us. I was heartened by the Minister speaking in the Health and Social Care Committee, talking about health impact assessments that will be undertaken across government. That kind of language will help us really understand the unintended consequences that get taken in one part of the system versus others. The language point is very important, and I have started to have conversations with the Director of Communications around how do we make sure that we use language that is engaging and not disempowering.
Thank you. Yeah, both for staff and for patients and the public. And
that's the role of improving together as well, to make sure that we are all aligned and recognise that we have many of the tools at hand ourselves to change the services we have.
Thanks. Can I bring in Rodri and then Paul?
Thank you, Chair. Just a few words. As a new member to the board, however, it's vast, it's a quarter of Wales, isn't it? I think we need to realise that. And what you said just now, Chair, the values, I think we need to remember that. And also, cutting kind of just parts here and parts there, that doesn't make sense. I think we need that long-term future kind of plan, because it's only going to be a short-term thing otherwise. And I think, I know we've got a huge deficit, but then we need to do it properly and sustainably as well. And I think, as you say, the values, and it's those patients that they're the important people, and the staff working with them, caring for them. So, yeah, I'm looking forward to the seminar. And as you say, perhaps it should be kind of looked at kind of in more detail in these boards.
Yeah. Many thanks, Rodri. Paul and then Judith.
Thanks, Chair. Clearly, the scale of the task is enormous, and 118 million is far greater than anything that we've ever as Hugh said it, that we've ever had to try and grapple with as a health board before. It seems to me that there are two sort of competing challenges, if you like. One is for us to be able to identify what might be achievable, and not wishing to prejudge the situation, but it seems highly improbable that we'll get to a position where we can close the gap by 118 million in the next 12 months. So from our perspective, we need to get to a position of identifying what's achievable, and achievable by having regard to what we know are the challenges that we've got, and the what we've already said and what we've tried to instill as a board about our values and the way in which we go about doing things. So what's achievable, having regard to that, but then what's acceptable, and clearly we need to get to an understanding of what might be acceptable, particularly to Welsh Government, in the knowledge that getting to 118 million savings is not likely to be possible. And we need to understand, therefore, whether what we can achieve will align with what they would find acceptable. And if there's a gap between those things, there's going to be a fairly significant challenge for the board. But if we can't get to the position of understanding what is the difference between what we can achieve and what might be acceptable, we're going to be in a very difficult position. So my question really would be, how quickly are we going to be able to get to a position in identifying what might be achievable from our perspective, and what dialogue can we have with Welsh Government as to what might be acceptable to them?
Thank you, Paul.
Yeah, Chair, in terms of that work, that is an ongoing focus. So I'll start with the achievable. That's the ongoing focus that we've got within our executive team, and conversations that we have each week to understand this at a number of levels. Firstly, the opportunities framework, and to test that against the delivery programmes that we've got and the programmes of change that we've got. And Sustainable Resources Committee has also had a role to play in providing assurance and overview of the opportunity translating into a delivery plan and a trajectory of delivery. That's the first element. The second element then is almost like the bottom up, and we're approaching this through with directorates in terms of the drivers of waste. There are 7 drivers of waste identified through the OECD paper written by OECD a few years ago, looking through that lens. So we give a framework to the organisation to understand where they are seeing waste within directorates. And that is building up to what we believe then an achievable plan, which we will bring back clearly in due course to the board. In terms of acceptable, we are clearly in a TI framework, and that means that I have very regular conversations with colleagues in the Finance Delivery Unit and in Welsh Government, and that is indeed the space where we're testing out what is acceptable from a government perspective.
Okay.
There is a fundamental issue here, clearly, whether a deficit this large becomes a cash issue, as opposed to necessarily a number on paper issue. It's a real cash issue, and that becomes quite acute. So we are putting extra resource in to understand, or extra focus, sorry, I should say, to understand how we best manage our cash, how we get to a place where our cash forecasting is as robust as our revenue projections, and because that cash forecasting becomes a really critical part for us. It's almost like any company that's entering a period of financial turbulence, the focus on cash becomes ever more important.
Thank you. And I think that question from Paul would be a good one to report to the board as we go through this year about what's achievable and what's acceptable, because as you've just outlined, it varies. At least the achievable may vary, and we need to be cited on that. Paul, you want to come back in?
It was more of I recognise the enormity of and the difficulty of it all and the challenges it faces. I just, from a board perspective, I just wanted to have a better understanding of the timing, really, I think, of, because we're 2 months away from the start, just about 2 months away from the start of the next financial year. So when are we likely to be in a position to have the information to be able to make these decisions?
Yeah, so I think the short answer, Paul, is the seminar will be able to present back on the progress that's been made, and I would expect that to be fairly final progress in terms of the plan we pull together for March. Clearly, with that needs to be aligned up against the discussions around acceptability with Welsh Government. So there is an iterative process, I think, around that. But I think it's also important to say, as we discussed yesterday, execs, whilst that may be the plan that we land, and you know, I'm very keen to ensure that what we have is something which we are in the midst of quite a lot of complexity, we are relatively confident of delivery of, and I think we need to ensure that we stay on that side of the line, that there will still be continued work through the year on improving that position, because there's a lot that we can possibly go at. So I would expect we will have the opportunity at the seminar to test our thinking and how far we've got, and be challenged by the board, so that we can then finalise that in time for March, with Welsh Government conversations going alongside that, but that the conversations will then continue into the new year on further opportunities as we can secure them. But I think we need a plan, as I mentioned, that sort of stabilises and is deliverable to start with, and sets us on the right track for the long term.
Thank you. If I bring in Judith and Chantel.
Yeah, thank you. I guess my sort of what I wanted to say is more a comment rather than a question, but I'm quite interested in the letter that's attached from the Minister, and particularly where there's some requirements and must-dos, I'd say. It's not would like, it's not should, it's must, which actually fit in with our strategy. So I'm looking at the issue about primary and community care, clear requirement to have more services in the community for allied health, rehab, mental health, audiology, and then that alignment of other plans, such as the cluster plans and the area plans from the RPB, which is a huge ask, but actually it's really what we want to do, but it's about the timescale. And then if you look at planned care, it also talks about that services, so workforce and funding to be moved from hospitals to the community. So quite a challenge there that we are required to do, and demonstrate how we deliver. I mean, people can read it, I won't read it out, but it's clearly the shift we want in our strategy. This is really the first time I've seen it so articulated this way from the Minister, and it's not a surprise, having been in a number of meetings, but I think that is an important part of how we do this, but also important how we link with the communication to staff and the public, that this does fit. It's not something new. Timing may be different. So I just wanted to make that point. I guess the only other thing I'd say, and this might only be me, I have a real issue with the language of bottom up. Sorry, Hugh, it's not just you. I just think when we say bottom up, and I hear some of our staff say, oh, we're at the bottom, so we don't matter. Can we just think about how we look for ideas from our frontline staff, whatever term we use, but can we please stop using bottom up?
Thanks, Judith.
It's
front to back.
Can I apologise for using that language? And in fact, the whole point of improving together is to recognise that we are having conversations that are conversations from adults to adults, not from parents to child or bottom to top. So that is not the language that we do use, but we do need to make sure that we correct ourselves when we do fall into the trap of using that language. So my apologies.
It wasn't personal, but I do have an issue with it. Thank you.
It's almost not even adult to adult, because the most important people are on the front. We're at the back, you know, so it's even, it's almost the reverse of what you've just said. I'm going to bring in Chantel and then Anna, and then we'll close the discussion.
Yes, I just wanted to go back to something that Paul said in relation to what's achievable and what's acceptable. And I'm just wondering whether the Ethics Committee has a role to play in that, in the sense is, so the language that we're going to be using in various conversations will be based on our values, will be based on the fact that we're concerned about moral harm to our staff. And I don't know whether Phil has a view, but I just feel that this is something that, you know, we should be able to offer.
Yeah, it's a good point, actually, because the Ethics Committee could have a role in two ways, couldn't it? It could have a role in considering the ethical principles of how we think about the totality of it. But it might have a role also in considering specifics.
Yeah.
And so we'll take that back, perhaps, Steve, and have a discussion as to how we might have a discussion at the Ethics Committee around that.
I think it's a really good suggestion, given the enormity of what we're facing. I think an ethical dimension, an ethical advice on that, I think would be really helpful.
I agree, and it really shows that this challenge that we are facing is online with what we faced when COVID came, and the Ethics Committee played a really important part of that space to be able to discuss and come to some decisions and guidance about ways forward. So thank you for that. Anna.
Yeah, thanks, Chair. I think this conversation is surfacing some quite helpful terminology, achievability, acceptability. It strikes me there's another one that begins with a capital A, and that's assumptions. And I wonder whether, as we develop this further, we should explicitly describe and articulate what our assumptions are that underpin those judgments about achievability, about acceptability, which would build in the point Chantal's just made around the ethics of the situation from the obvious point of view, from ethical impacts on patients and our staff, and the ethics around carrying a deficit as big as this one is. There are multiple ways of considering that issue that take us into probably a whole new world as far as our board responsibilities are concerned. But I think articulating those assumptions that we're making in those judgments about different options, different scenarios, are going to be really important in holding ourselves to account, but more importantly, having a transparency with our communities about just how challenging these issues are, and how that sort of conventional principle that efficiencies through NHS organisations are delivered more or less invisibly as far as patients are concerned is probably a principle that is redundant.
Yeah, thank you. Thank you for the paper. And I think that was a really, really important discussion. And I know it encroaches on other parts of the agenda, but it was right that it all came together. If I could just very, very briefly summarise, what we would like going forward as a board is the concentration on clear language. We will discuss the governance, which is also linked to the transparency, so that these discussions continue to be held and decisions publicly, that we look at the assumptions, the achievability and what's acceptable, and the timescales when we are discussing, and we base this on our values and ethics. So we will explore the role of the Ethics Committee in this, which would be another forum to give some time. Now, we've got the seminar next week, and depending on there is sort of the outcome of the seminar or where we get, we may have another seminar again to continue this discussion, to give it the proper concentration and light that it needs before we get to the next board meeting. So thank you, everybody. On that basis, is the board happy to agree the recommendation, which includes approving the submission of the accountability letter to Welsh Government to confirm that a financially balanced plan will not be submitted? Yeah. Okay, thanks everybody. Next item on the agenda is laid you again, implementing the Healthier Mid and West Wales strategy.
Thank you, Chair. So the paper set out a brief update on the work being undertaken to progress the business case and support the strategy. I think everyone's familiar with that now. There are 4 key areas that we're working on as the paper sets out. So firstly, the clinical strategy review, where Welsh Government are commissioning an independent review of our clinical strategy, which is now a standard part of the process for major capital schemes of this scale. We've agreed terms of reference to the work, and it's hoped now that the work will be undertaken through April, which is a slight delay from what we had in the original terms of reference, just because of the procurement process within Welsh Government. We're also commencing work on a strategic outline case for the new hospital, Glangwili and Withybush combined, the 3, as per Welsh Government's request. And again, this is to ensure consistency with similar schemes across Wales. We've submitted a resource schedule to Welsh Government to enable us to deliver that work, and we're waiting a formal response in relation to that. Land selection work continues to do the survey work and support the land selection process in general, including discussion with the landowners, as we've talked about previously. And then the most material item, I guess, at this point is the land consultation. So that planning for that consultation is now quite an advanced stage, with a go-live date now planned for the 23rd of February. That's 4 weeks later than we'd originally planned, as per the last board papers. Part of the reason for that was the need to quality assure the documentation, and board members will note the Consultation Institute's assurance of the scoping and governance gateway and the consultation documentation gateway. So, subject to all of those 4 areas progressing as planned, we are intending to hold an extraordinary board meeting towards the end of August to bring the 4 updates in those areas together and consider our next steps for the programme. So that'll be another important milestone for us. One just final point then before for questions was just to bring the board's attention that we have received notification of ministerial approval for the outline business case for the Cross Hands Health and Wellbeing Centre. So board members will remember that came in July, and then instruction to proceed to the full business case. That's excellent news for us, obviously, as a board, and a significant milestone for the project.
Great.
Thank you.
Thanks, Lee. And do you know how long the business case will take?
So we're hoping the full business case will be completed towards either the end of this year or early next year, and then ultimate construction probably conclude towards the end of 2025.
Okay, great news. Thank you. Questions? Sam?
Thank you, Chair. Firstly, I just wanted to thank Lee, his team and colleagues for working with us as closely and openly as they have done, and we're looking forward to the public consultation. That's been a really helpful process within the information provided in the paper. I did have one question to you, Lee, just on the clinical review, and I just wondered if you could, I know the answer to the question, but can you confirm that the clinical review is going to incorporate the shift in kind of current operational realities and challenges, which are quite different to those back in 2018 when the public had their opportunity to have their say in the Transforming Clinical Services consultation? And I ask that because people who were unsettled by some of the proposed changes then are even more unsettled now because of the current picture of emergency care challenges and frailty, fragility in primary care, etc.
Yeah, okay. Yeah, I think that's a fair question. So I think the review is primarily one of direction of travel. That's the question that it's seeking to answer. Are we pointing in the right direction? Is what we're intending to do the right approach for our communities, our population, and to respond to some of those challenges. So I think our view on this point, and picking up on some of the comments that Hugh was making earlier, is that directionally it's still where we need to get to in terms of the focus on population health, preventative medicine, services closer to home, and so on. And then the acute pressures we're facing and some of the challenges that brings to the delivery of services and the sustainability of those services, I think has really just re-emphasised the need for what we were planning to do within the strategy. So I think it does bring a question of deliverability and the scale of the task over the time period that we've got in mind, given what's happened, as you suggest, Sam. So I think there is a question for us increasingly in relation to that. And that comes back to some of the points that we were talking about in terms of delayed transfer of care challenge, or the work with our local authorities, but also workforce pressures and so on. But I guess the key point is that is it the right direction of travel, and then following that, what do we need to do in order to deliver over that time period, and that includes some of the other aspects that are mentioned in there, like digital transformation and so on.
Thank you.
Could I bring Phil? I think it's on the same point.
Yeah, just on the same point. So inevitably the whoever's commissioned to do the clinical review will be looking at their work and looking at the work that we did through the Transforming Clinical Services programme with eyes that have seen what's happened through the pandemic, and also knowledgeable about advances in management and thinking that have taken place over the last 5 years. So I think they will include that in their thinking, inevitably, when they look at the work that we did back in 2018. And it will be helpful for us, actually, to have those eyes, and there may be things that we can learn from.
Thank you. If I can bring in Paul.
Thank you, Chair. Couple of questions. The timescale, first of all, for the clinical strategy review, we're currently anticipating that that's going to be completed by April. Seems like there's quite a lot of work to do, and we haven't yet commissioned that. So is that timescale realistic? Are we going to be in a position to get the outcome of that review by April? Second question would be, to what extent the outcome of the clinical strategy review might impact upon the wider public consultation, and if so, is there a risk in running the two things in parallel? And the third one would just be an observation on the terms of reference and as to whether we should be recording what documentation we're providing to the review in order for them to undertake the exercise.
Thanks, Paul.
So firstly on the timeline, so it's Welsh Government procuring the clinical review process. As I mentioned, it is slightly delayed than what was originally intended. So they're hoping to have somebody on board towards the latter part of March and then conduct the review through April. So the report itself is probably going to be a little later than what we've got in the terms of reference because of that delay. That was the point I was describing earlier. That delay is potentially important for us because the question then, and it leads into your second point, Paul, is to what extent that will influence our strategic outline case, because obviously what we would hope is that it would largely endorse what we're trying to do from a direction of travel point of view, but there will undoubtedly be some aspects that we're going to need to reflect on and incorporate into that strategic outline case. So the scale of that will depend on whether we're then able to achieve the strategic outline case by the summer as we've set out. So we can't prejudge that, but that's where the timing of that clinical review could have a bearing on what we're trying to do over the next period of months. So it will certainly influence the strategic outline case. I think it has less of a bearing on the land selection consultation because that's a very focused question, not so much on the strategy, but on the which of those three sites is most preferable for the new hospital specifically. Clearly, though, through those conversations, there'll be broader discussions with our public and other stakeholders about the strategy more generally and where there might be some opportunities. And I'm sure, I guess part of the thinking with bringing all of these items together in the summer would be it would allow us the opportunity to bring all of that information together and then have that rounded view of it. So that's the second point. Sorry, I've lost the third point. Was I'm trying to remember, Paul.
It was a question about the documentation, I think.
Sorry, yes. Yeah, so we'll supply all largely it'll be the information that we've presented through board papers anyway, so it'll be everything that's in the public domain. But we'll certainly record that, and when the clinical review comes back to board, we'll make it clear to board members as to what's been provided to that review team.
Chair, we could offer to help with our archivist for that, Lee, to pull that information together with you as well, so we've got a formal health board record.
Thank you, Jill. That'd be helpful.
That's great. And I understand that the board meeting date has already been set, so it'll be a single issue board meeting to give it the proper attention and consideration. And what date is that?
It's the 24th of August, Chair. It will be in the morning, and we've already advertised that publicly on our website already.
Super. Thank you. Lee, taking into account the previous conversation that we had in relation to finance, who will be funding these two pieces of work which have been requested by Welsh Government?
So the clinical review is entirely funded by Welsh Government. The strategic outline case, we've submitted a resource schedule to Welsh Government, which they're currently considering. And then obviously, subject to that response, we'll have to take a view on that. But at the moment, the indication is that Welsh Government will be funding the vast majority, if not all, of those costs.
Thank you. That's good to hear. Thanks very much. So is the board happy to accept the...
Oh, sorry.
Sorry, Judith, excuse me.
It's all right. I don't want it to pass because it's felt like a very long gestation, but I really want to welcome the decision about cross hands.
Yeah.
It's such an important part of the overall strategy. And I suppose I'm seeking, assurance that we use the lessons from implementing the Cardigan Integrated Centre when we come to the detail about cross hands, which will bring in, I think, still 2 general practices as well as the community services. But it's really welcome that we've finally got that decision. I'm glad I've seen it before my time with this board finishes. I never thought I would. So I'm really pleased about that.
Yeah, it's good news, and I think it demonstrates that the point about us trying to progress those community facilities alongside all the bigger work around the new hospital, Glangwili and Withybush and so on. So then we're not holding those up, if you like.
Yeah, absolutely. It's really important that they're there before the new the new hospital. So thank you. Thanks, Judith. Sorry about that.
No, it's fine.
The board happy to accept the recommendation? Yeah, thanks, Lee. So the next item on the agenda, Mandy, improving patient experience report.
Thank you, Chair. I won't go through the detail of the report, but there are several points that I would like to highlight. So I think it's fair to identify that the data that is provided within this report reflects the period of October to November 22. I know that at the recent operational quality meeting, a different time period was identified. So anybody that would have seen the reports through that would have identified a different set of data. And I think it's important that we recognise the data changes continually. During this reporting period, I'm really pleased to say that the number of compliments that have been received about our staff and our services has actually increased. And it's really heartening to see that over 4,000 people out of the 33,000 surveyed in the period have actually taken time to provide us with really valuable feedback about their experiences. And whilst overall the rate of positivity in the feedback that we get is quite significant, it's in the 90%, which is really positive, that still means that 7 to 8% of the patients that we serve experience a poor service or have a reason to express concern about their experience. And that is an area that we will continue to try and drive down through the improvements that we make. Complaints, however, have seen a marked increase during this period. And we have seen that a couple of themes have continued to be present within those complaints. 25% of all concerns received have focused around clinical assessment and treatment, and that is something we need to explore further. 24% have focused around delayed and cancelled appointments, something that we've already discussed earlier in this meeting. And sadly, 23% continue to be about communication. And I will come back to communication when I talk about the fundamentals of care standards and audits that we've presented later, in the next item. The patient story that's within the patient experience report, I think, is quite impactful. It was received at our Quality and Safety Experience Committee, and because of the relevance of the points within it, it was felt that it needed to be presented to board through the patient experience report. I'm always very, very grateful when patients and their family members support us in our learning by sharing patient stories, because patient stories are one of the single most impactful mechanisms for hearing our patients and their families' experience. I think the disappointment for me in this particular story is the fact that repeatedly the patient and his wife had to tell every member of the team that they encountered their story repeatedly. That is unacceptable. Sadly, it's not an isolated incident, and it comes back again to communication, handover of information between our teams, and the fact that there are multiple handoffs and handovers between team members before a patient can actually get to having the treatment and investigations, etc., that they need. The other issue that has come up, and again, it's a reflection through the complaints that we receive, is about the lack of privacy and dignity that lack of privacy provides for a patient. And I think that the one thing that I would say is that a common theme throughout the complaints is that our environments of care do not lend themselves to positive patient experience. Whilst we have excellent staff striving to provide excellent care and support for patients and their families, the care environments in which they're having to do this are not now continuing to be as fit for purpose as they need to be. And that is particularly evident in our front of house, so our accident and emergency departments, as well as some of our inpatient areas as well. And I think that serves to highlight the importance of moving our strategy forward at a pace. The one area in the feedback that we received highlighted concerns particularly about our outpatient department in Glangwili Hospital, and that is something that I will be taking a further review of, because I need to understand exactly what's going on in that area and what we could do better to support our patients. Finally, going forward, and the team always have great plans for improving the report, both in terms of the format and the content of it. A couple of things that we're looking to do more consistently now is try to provide a much rounder picture, so ensure that we're not focusing, which we try not to do, just on the acute service, but actually I want to see regularly in each report some reference to the feedback and the experiences of patients in mental health and learning disability services, primary and community care, because we have already now more consistently got feedback that we can share around our acute and paediatric services. The second thing that I've asked the team to explore is how do we move towards providing more trend data within the report, so that you can see, because it's often difficult, isn't it, when you look at a snapshot, have things got better, have they got worse, have they stayed the same, despite the multiple interventions that we're putting in. So that's the second thing. And then finally, the report, I would like to try to move towards having a section or a paragraph in there that talks about how we've triangulated the information that we have available to us, not just from the complaints and the feedback that we receive and the compliments, but also things like our quality and safety dashboard, where we're focusing around harm, as well as staff feedback as well. So I will pause there, and I'm more than happy to take questions.
Thank you, Mandy. Open to questions. Rodri.
Yeah, just one then. Thank you. I think this report is very good, and the unfortunate thing, most people are very thankful for the service, but people like to complain more so than what they like to perhaps give their praise at the end. The only one, I think, is page 11 of 32. Just, I know we've touched on it, the 30% of concerns linked to communication, right, or incorrect information being given to patients or families. Just enhance on that. What does that mean? Is that kind of false information regarding patients?
So I think, in fact, in the last fortnight, I've met with several complainants and their families, and they are raising concerns about communication. They're raising concerns about lack of timely information to make informed decisions. The other thing that has been raised is we do not manage expectation well. And I mean by that the fact that because we don't share timescales, for example, so we might say to somebody, we hope that the report will be back, the diagnostic will be back next week, when we know it's going to take at least a fortnight to 3 weeks. So that's the managing of the expectation that I think we need to do more of. There is always more information that we can give to people, and certainly the waiting list support and the single point of contact, the communication hub that we're developing, is a mechanism that we can signpost people to further information that's going to help them manage their condition as well. So that's work that we have got to take further forward.
Thank you. I'm going to bring in Anna, then Paul.
Thanks, Chair. Mandy, really pleased to hear that you're thinking about trend data here, because I think it's ever important to look at how these metrics are changing over time. I think on communication, I might also add into what you have described by way of potential actions, that we should think about how we can enable our patients to take some of that responsibility, by which I refer through personal experience to the Bermuda Triangle that is Glangwili A&E, where if you don't have a smartphone and can connect to the Wi-Fi, you are unable to communicate with your family. Now, if we could open up that line of communication, I think it would save an awful lot of work going through the switchboard. Just a very specific example there, but I think we need to think of our own patients as part of that communication solution. I wanted to pick up on something specific in the data, and that's around the graphs on slide 17 around patients feeling safe and well cared for. And that, for me, really leaps out that over 4 in 10 of our patients don't feel safe and well cared for. And I have to say I struggle to reconcile that with the same data set that says that the positive experience is over 90%. So there must be around 3 people who feel unsafe but somehow feel positive about us. So I think that sort of growing sophistication that you're describing in the way that we triangulate the data and understand what it's really telling us is really important to do. But I wondered if you did have any comment you're able to offer specifically on that safe and well cared for metric.
I think it's a really challenging one, but it's a really important question to ask. And often, although I would have to look at further evidence around this, people don't feel safe when they haven't got information about what to expect to happen to them next. They don't feel safe if they don't know what is happening to them when a professional approaches them. So again, it goes back to communication, and it goes back to the level of information that we provide to our patients. On the whole, I'm not sure that I'm seeing much that says they feel unsafe because of other people around them. In previous organisations, that has come up as an issue, but that isn't something that I see here. There are some concerns, and it's something that we've discussed through the Health and Safety Assurance Committee about the levels of violence and aggression. We do have a high number of patients in our clinical areas with a cognitive impairment, and if you're not familiar with that, you can perhaps feel a little intimidating, perhaps with a wandering patient. However, we will do some further deep dives on this so that we can really understand, because if we don't understand it properly, we can't put the actions in place to resolve it. So not a complete answer, but that's certainly from the intelligence that I'm seeing as well as the complaints that I hear.
Thank you. I can bring in Paul and then Chantal.
Sure. Thank you, Mandy, and thank you for the comments about improving the report for future iterations. It's almost as if you read my mind. Looking at one of the slides, slide 12, about palliative care, and you referenced the Listening and Learning subcommittee, which, as you know, I chair. And it's partly an observation and then a question. The most recent meeting of that Listening and Learning subcommittee, where we discussed palliative care, and it was clear from the meeting the impact which caring for people in that environment is having on our staff. I would probably describe it as one of the most traumatic meetings that I've ever chaired at a health board, and really insightful and opened my eyes really, as I think, just to the sort of pressures and stresses that this sort of environment imposes on our staff. And I was left reflecting really as to how we support our staff who are working in that sort of environment, and the impact that having to care for people in those sorts of circumstances can have on them.
Yeah, and I'm very aware, because I've had quite a lot of feedback from senior managers actually who were listening into that story about the impact that it had personally on them. I think it's fair to say that there are a number of mechanisms that we have within the organisation that certainly Lisa's team have been really instrumental in driving forward. So as well as our wellbeing service, which is there for any member of staff to be able to access, certainly in palliative care, they do, as I would expect with all of our teams that are delivering front-facing patient care, have an opportunity around clinical supervision and psychological support that they also offer to their patients and their families as well. I don't know, Jill, whether you want to offer a comment around anything other than to say that obviously as part of our palliative care strategy that is being developed, how we support our staff in those highly emotive services is going to be critical in terms of the outcomes that we're able to provide for patients. But Jill, I don't know, I've put you on the spot. I don't know whether you want to say anything.
Thank you. I think that's a really important point that you've raised. And I have chaired, it's now taken over by one of my senior team, what I call executive group of the senior doctors and nurses who work with those teams. And staff wellbeing and psychological wellbeing is extremely important. And we've had some very emotive conversations about how we do that better. And, you know, a lot of these staff also work out in our communities. We don't have hospital-based service per se, and so can be quite isolated. That relationship with the family is also important in terms of ensuring that we've got that right level of support. So our strategy has been very much focused on how we do this better and developing a three counties model that is ensuring that we've got the right leadership in place and the right support. And we're also looking at bringing this into almost a clinical directorate in its own being. We haven't recognised that previously, but we believe it's really important that we do this. And particularly through the pandemic, I think, we saw the need ever more for that level of support going out into our communities, on our wards, and supporting our families, but also our staff. What we've also had, actually, as a consequence, probably of some of that pressure, is a high level of sickness within our team. And I know this has been recognised, particularly in Pembrokeshire, actually, where we've had, for a period of time, very limited resource because of that level of sickness. So we've been looking to staff across Ceredigion and Pembrokeshire to support us and support families so that there wasn't a gap in service. I'm pleased to say that we are seeing over the last month some of those staff coming back and some new appointments into the Pembrokeshire team. But we continue with that three counties support, and we're also going to be moving now in line with our strategy, the appointment of a clinical lead nurse and a clinical lead doctor across our three counties, so that we continue to move on to that whole strategy. But I can't emphasise enough the importance for staff wellbeing and support, and not just actually this team, but I think particularly for me as well anyway, as the executive lead for this service, I found it quite an emotional connection with this service, and as I say, particularly through the pandemic, where we saw staff continuing to go out and support families. I just can't emphasise enough the importance of this, and I think to hear board members who probably traditionally haven't connected with this group of staff and perhaps that experience, to be able to reflect how it's affected them is actually really important as well. And one of the things that I talked about before is that we might want to bring a staff story as well into our board as well. And this service, now that we've moved a little bit forward with the strategy, it might be a good time to do that. So I think if we can organise that with the board secretary at a point in time, that may give others members of the board as well the opportunity to experience some of this again firsthand.
Thanks, Jill. That's a really good idea. And when the independent members discussed the papers in advance of the board meeting, and Paul made these points, and we also saw the community nurses' annual report in the papers, we all agreed that we need to hear more directly. Like you, I've been out and listened, and particularly during the pandemic, and heard the isolation to the extent, you know, the simple things are important. All public toilets were closed, you know, as they're going round trying to serve. And so as a board, I think we will take away from this how we bring their voices either to the board itself or even a bigger session to a particular committee. But we'll take that away as an action. So thank you for that. I'm going to bring in Chantel.
Yes, thank you. I just wondered, you know, whether this report, for example, should be featuring within the People's Committee, because we should be really looking at training opportunities in terms of how do we skill our staff in order for them to become resilient in terms of dealing, because we do know that there are significant challenges for the organisation, but we need to have specific training engagement in order to ensure that the staff will be able to deliver on a kind of day-to-day basis.
I wonder whether perhaps what might be helpful, because obviously the experience element of our services sits firmly within our Quality Safety Committee. However, the education, training, development needs is something perhaps Lisa and I could liaise over, so that the element of the report that needs to come through that particular committee can perhaps be highlighted. That might be a good way of taking that forward.
Yes, brilliant.
Okay, thank you. Well, Dennis.
Thank you. Thank you. Most of my questions have been answered, especially about primary and community care and actually obtaining feedback. But can I take us back to the service user feedback at a glance on page 4? And when we say that 33,281 individual requests have been sent out and we only receive just over 4,000, and that's in line with national figures, is there a piece of work nationally looking at how we meaningfully gather patient and family feedback? Because to me, is that the most efficient way of actually gathering feedback from our patients and our families? And it just makes me wonder, should we do something differently as a health board, or is there something nationally, there is some work being undertaken to really look at getting the real nub of the issues for our patients and our families?
I think it's a challenging one, if I'm brutally honest. So the new Civica system is a national system. The approach that we're using is a national approach. And I mean, let's face it, we're all probably survey fatigued. I don't know how many surveys I personally receive on a daily basis, and I don't choose to answer half of them unless I've got a bit of a gripe. And I think it goes back to Rodri's point about you bother to respond more likely when you've got something that you really want us to know about that perhaps hasn't been so positive. You know, we text message, we survey, we email, we telephone call, and if there is another solution, then I'm happy to receive that. I think the other thing to say is that let's not forget, we also have our PALS team collecting feedback regularly as well, in terms of the telephone and multiple telephone calls that we receive. And in fact, I will be taking some further detail to share with executive colleagues, but also into probably our quality committee around the level of engagement and capacity and resource that we're utilising to engage with patients and their families.
Okay, thank you. Well, thank you, everybody. Thanks to the whole team for this report. If I just again briefly summarise, but first of all, I'd like to ask if you could consider whether we have the patient story within the report, whether we go back to commencing the board with a live showing of the patient story, as we did before COVID, and consider also using a staff story. So we kind of go back to that, because even though it's in the report, it's not shown in this meeting, and it does sometimes change the way we look at things when we are reminded at the very beginning of what we're here to do. Really welcome that the report's going to be expanded to bring in the patient experience of mental health, learning disability, primary and community care, and the trend data. Really, really important. And also the triangulated information. So, for example, in the report for some of the friends and family tests, most acute wards really score very high, but there are a few that don't. So we need to dig deeper. Is this a trend? What else is available? And then bring that back if we could. And similarly, when it came to some of the complaints about, I think it was in communication, there were 3 in rheumatology, which was more than elsewhere. If we can just dig a wee bit deeper on that. We've agreed that we will bring the community and palliative staff voice to either board or committee and have an update on the development there to support staff. So I'll leave those discussions for outside of board, and the element of training to go to the people committee so that the people committee can give the benefit of their advice and experience. So massive thank you again. This report is so important. We've made sure that it's featured throughout the pandemic when we couldn't hear directly from patients, and the team are doing, you know, a marvellous job, and it is evolving and maturing. So thank you very much. Board happy to accept the recommendation. Thank you. Well, we're going to have a 10-minute comfort break now. I can tell by the smiles across the room that that's going to be welcome. So I don't know what time it is. Is that on a computer?
10 past, yes.
So
Back by 20 past.
20 past 11, we come back. Diolch, thank you everybody.
Sorry, Chair. Just manage the bits of paper. Thank you. Okay, so thank you. This, as you will see, is quite a comprehensive. I won't go through the detail of it because it's there for people to have read, and certainly we have taken this report through the Quality Safety Experience Committee as well, so it has had quite an in-depth opportunity to be scrutinised. I think it's fair to say that the previous reports that have been provided have been based upon a data collection exercise that we undertake using the health and care management system, which we are no longer using. And the relevance of that is that it is quite burdensome on nurses and others to actually input the data into the system. The Welsh Nursing Clinical Record, which has been introduced very successfully across the inpatient areas of this organisation, is now the mechanism and the vehicle through which we are capturing data. So there is a specific audit tool that sits within that electronic system. And that does significantly reduce the burden, not just on staff entering data, because it's able to take from the entries within the record some of the information that we need to populate this. But actually, we are also continuing with a degree where it is appropriate, and we haven't got all of the assessment tools within the system, a degree of observation of practice as well. And I think that's important because when we use data out of a system, it doesn't eradicate the need for still some observational activity to go alongside it. So the findings within this particular report have been modelled around the 6 domains of quality, which we anticipate will be the 6 domains that will be used within the duty of quality, the Quality Engagement Act, that we will be expected to go live on from the 1st of April. So I think it's fair to say that we're trying to get ahead of the game and make sure that we're focusing around safe, timely, equitable, efficient, effective and person-centred care. And that's how we've presented the findings within the report. So hopefully that's the model that we will see in a number of reports going forward. There are a number of things that I want to call out, but I do want to just make the comment that you will see that patient experience has not been included. So the feedback has not been included in this report. That's something we're going to look at as we go forward. So as the Welsh Nursing Clinical Record Audit tool and the additional assessment tools that will be feeding into that come on stream, we will also be looking at how we utilise, and again, go back to that triangulating. How do we understand the standards from a variety of different avenues? So that will come into future reports. The 3 specific areas that I believe that we need to give further attention to as we go forward. One of them actually is my own personal view and reflection, again, based upon feedback from complainants and from people who have had not positive experiences of our service, but some are called out in the actual audit. So mouth care, I have to say I'm personally extremely disappointed that this score has not achieved the results it has in the audit, partly because we did an extensive programme of work around mouth care back pre-pandemic. It's an area we will be revisiting with our dental colleagues, community dental colleagues, because they've been so great in helping us focus on some of the priorities. Nutrition and hydration, and again, that comes from feedback that I've received from individuals about not just the assessment tool being undertaken in a timely enough way, but actually we need to get people to look at the person in front of them and not rely upon a set of diagnostics. If somebody hasn't had sufficient intake of fluid and nutrition, we shouldn't be relying upon a set of blood results to tell us that they're dehydrated. We should be looking at it, we should be recording it, and the nutrition and hydration risk assessments need to be updated in a timely enough way. That is not the position we're in at the moment, and again, there is further work being done on that. The other thing that I feel very strongly about is continence care. again, based upon feedback that I've received very recently, and in fact from several individuals, there's more work for us to do around continence care. The use of the continence passport is not being, the catheter passport is not being routinely and consistently given to patients who have been in hospital, who have required a catheter, and then go home. So that is something that already I have spoken to the lead nurse for BABAS, our bowel and bladder service, to actually look at, so what more can we do? And we will be looking at some very specific focused activity there. The other thing to say is that, again, I've actually asked the lead nurse to liaise with one of our individuals who has provided some feedback about their experience to review the pelvic health webpage that we did a bit of a soft launch on 2 months ago now, to look at what have we got on our webpage about living with a catheter. So that hopefully will help us make sure that it is very relevant to individuals who need continence care and management. Then finally, the area that has been identified within here is discharge planning. And as we know, given the level of pressure that we have within the organisation, we do need to focus more on what we can do to actually have timely, effective, safe discharge for our patients in our hospitals. And I have a meeting coming up with the discharge liaison nurses across the organisation to look at what more could they be doing. Is there something about consistency? Have we got a common job description? Are they really clear about the priorities that they need to be driving? So hopefully that will then in turn inform any further work that we need to do around the discharge planning, assessment, documentation and standards of care. And then finally, linked into the discussion we had earlier around patient experience is communication. So whilst it's not explicitly called out within the body of the report, it's something that weaves through everything that we're identifying as areas for improvement, whether that's about mouth care, nutrition and hydration, whether it's about continence care or in fact discharge planning. So that again is something that we need to do some further work on. What I think is important to say is that the Making the Difference programme that the training and education team have been leading on is beginning to have an impact. It's certainly driving our values. And again, it's not, you know, I believe every individual nurse, doctor, therapist, every member of staff within this organisation comes into work every day to do a good job. Sadly, we get it wrong occasionally, and that's what you see within these fundamentals of care audits. This is a snapshot, however. And I have no doubt that if I went out today, the scores that you see within this report will be different. And that is why we have the opportunity, because it is captured through the WNCR, the Welsh Nursing Clinical Record, to actually go in and monitor in more real time. So I'll pause there and I'm happy to take any questions.
Thanks, Mandy. That was really clear. In respect of those areas that you've identified which causes you the most concern and which work is going to be undertaken, where will that be reported back in governance terms as on an ongoing basis?
So I would expect there to be discussions through our Operational Quality Safety Experience Committee, and then, as we've done previously, take work through either our assurance report, or if we have something very specific, we can utilise a patient or staff story and then actually a deep dive into that particular area. So that's something I'll work with Anna as chair of the committee in terms of building it into our work programme.
Thank you.
Because they are fundamentals.
Absolutely, thank you. And as you know, we met with one of the complainants or two of the complainants together, so it's wonderful to see that they've been listened to and it's taken forward. Chantel.
Yes, just a quick question. I mean, looking at the data and your disappointment, is whether you can drill that data down to ward level in order for us to be able to address the concerns at ward level.
Yes.
Because it seems to me that, you know, we're looking at the data broadly, and in order to make those changes, you know, the responsibility has to lie with the people who are working on that particular ward.
Yes, absolutely. So every individual team and area that participates or are included within the audit have their results fed back to them. And the expectation is that the sister charge nurse, team lead and the senior nurse take absolute action on improving that. So, for example, in one of our areas where nutrition and hydration featured as a particular issue, there is now an improvement board. There are some training sessions that are taking place, and they've really grasped that it's not a position and a standard that they want to own. They want to make it better. So it's very much, it's fed back to the individual team and service as the results emerge.
Thank you very much for that.
Judith then Delic.
Yeah, thank you, Mandy. It was really good, and also listening to what you said about the things you'll go into. I suppose one thing I noticed going through, and I wondered if this is presented in other forum so you can look at a site and look at all the indicators, because, you know, going down you think, that same lack of compliance, I'll put it like that, is appearing across all indicators in the same place. So do you also look at it like that? And then, so that was one thing. And then my other part of that is that I'm thinking ahead to the next paper, whether that then does correlate with information that the Workforce and OD team are having about issues within that same location, and do those things, that information come together?
So first, I think it's important to say we can cut this information in a variety of ways. So what you've got here is the high-level report.
Yeah.
So we can drill down by ward, we can drill down by site, and the corporate team certainly do that so that we can focus our improvement resource and through our practice development nurses very often into those particular areas. In terms of, my brain's just gone blank. What was the second point, Judith?
The correlation.
Yes, the correlation. So sorry about that.
Any of the stuffing.
I think what is fair to say, we have now also started to use in more detail the quality and safety dashboard. So we've got a set of metrics there, and already we're able to see by site if there is a hotspot that's beginning to appear over a range of metrics, not just one specific. And the other thing, the opportunity that I believe the Improving Together sessions with our operational teams are going to have is that we can actually give a greater focus on the areas that they are struggling with. So going back to my comment about we all come to work to do a good job and to improve things, if they are struggling, we need to understand why so that we can put the right solution in. And that's where I expect to have those conversations about the level of support that they will be able to have. So hopefully that addresses
Thank you. And
that.
Lisa would like to come in as well on the same question.
Thank you. And just to add to that, our OD relationship managers receive the information and they are looking to move more upstream in the work that they do to triangulate that. And also our education team, in terms of the Making a Difference programme, are looking at areas where in those reports that Mandy's presented we are seeing problems, to see are we getting staff attending from there, and if we're not, how do we target those staff to attend?
It's really great.
Thank you. It's really, yeah.
Step forward.
Thank you. Really assuring to hear the joined upness. Delith and then Winston.
Thank you, Chair. It's leading on from those questions, really, and thinking about the whole skill set on a ward establishment. Am I right in assuming that this nursing record is completed by qualified staff? Because when we look at skill mix on wards, we do have unqualified healthcare assistants actually performing a lot of these tasks. And I'm just thinking about educating on a ward-based as well as a directorate level, that we ensure that all staff are educated to the same standards. And is that taken to Workforce and OD?
So in terms of who can make entries in the record, there is a wide variety of staff that can actually make records entries. And I think what it has done, it's slightly off tangential, but what it has done is driven the desire for other professional groups to have access to a single clinical patient record. And that is something that we need to continue to aspire to achieve. But the unregistered workforce, if they are appropriately trained, which certainly if you're looking at, and we had at the last board meeting, the example of the assistant practitioner role, then they can, of course, make entries. doesn't take away from the fact that the registered nurse remains responsible for the care that is given to those patients, the observations that are recorded. But they are able to make entries, and certainly our therapy colleagues are making entries in the record, some of our medical colleagues are making entries in the record. So it's almost becoming a bit of a multidisciplinary record. However, it is still focused around the nursing assessments and requirements that we have to make.
Thanks, Mandy. And is it true that we were the first health board to introduce this? Because I do remember meeting the team during the introduction, and they were absolutely, delighted to have this tool, and they really drove the implementation.
Absolutely. So Ward 11 in Withybush, I will talk about Rachel and the team there. They threatened that they'd chop my hand off if I took the system away from them, even though they were only piloting it for the rest of Wales at the time. But I think it's fair to say it's been rolled out across. We were the first to roll it out in the way that we have. And as I keep reminding people, we did it in the midst of a pandemic. So I work on the basis, if we can do that level of change in a pandemic, the world's our oyster.
Absolutely. Inspirational, thank you. Winston.
Yeah, thanks for the report, Mandy. I think your presentation really brought it to life. I just want to pick up on two things. First one, safeguarding, where you sort of pull that out as an area. I know it's improved since June 22, but you pull that out because, and just explain first of all, safeguarding in what context. Is it vulnerable people, vulnerable adults, children? That's the first thing. Second one I want to do is to compare safeguarding to the domain under patient-centred care, and in particular on respecting people, because on here the actual scores for compliance are a lot lower than safeguarding, but you haven't brought that out in your summary report. So it'd be interesting just to understand why, and also what we're going to do about the respecting people domain as well, because it seems a concern to me.
Yeah, thank you for that. And I think probably the reason I haven't highlighted the safeguarding piece is because there's a lot of work already going on and has gone on. And in fact, one of the things that I want to take to the Quality Committee is evidence around the level of compliance around our safeguarding activity for both adults and children. So that is individuals who are within our service who there is a degree of vulnerability or risk that requires them to be put into the safeguarding process. The element that we are looking at here is around the assessments that have been undertaken, the referrals that have been made, and the safeguarding team are very proactively working with operational teams. You may recall from a previous board meeting, we had a discussion about, so what are we doing in our A&E departments, for example? Do we seem to have a bit of a problem? And in fact, the team have gone in there and done some very specific work with our A&E colleagues, and that has seen an improvement in the referrals that are made.
I think, Mandy, what I was saying was you've highlighted safeguarding in your report, but actually there's a lower compliance in relation to patient-centred care, in relation to respecting people. If you look on page 9, you see that the compliance levels of that are much lower, but you haven't highlighted that. So I'd just be intrigued to understand if there's something we're going to be looking into that particular area.
Yeah, I think it's fair to say that the points that I've highlighted are points that I'm hearing about more frequently. It doesn't mean to say, even if we have scored 100% on anything, that I'm satisfied. The teams know that if they score 100%, it usually attracts more attention. Because I'm afraid I like to test, not just those areas that aren't scoring highly, but those areas that are scoring very highly. So anything that is featured in this report is subject to further scrutiny, further discussion with individual teams. And the one thing I would say is that because I have the responsibility around the Nurse Staffing Levels Act, every 6 months as a minimum, the clinical areas that fall under certainly the 25B areas, so the acute medical surgical areas, but increasingly other areas, they talk to me not just about their staffing, but about their quality metrics, their standards of care, their staffing, their sickness, their PADRs, and they are held to account for the standards that they're able to deliver within the staffing establishment that they have. So whilst this is a point-in-time report, it's not something that's static. So, yeah.
Thank you.
Andy, leading on from that, on page 4 of the report under personal hygiene, it says that cleaning schedules compliance are showing an improvement with more sites achieving 100%. So picking up your 100% comments, I did have a meeting just before Christmas in one of our hospitals with the housekeeping team, both the day staff and the night staff, and they raised their concerns about the equipment that was available to them to be able to do the job properly. In particular, the different coloured mop buckets, the vacuum, the things that clean the floor. And I'm going back with Lisa on February the 3rd to feedback on other issues, and I just wondered where we were in relation to giving staff the tools to do the job.
Yeah, so there's been, and in fact through our use of resources meeting, we've had quite extensive discussion about cleaning standards, and that is something that is an ongoing conversation, because we need to make sure that we are achieving consistently the level of cleaning that the areas require, whether that's a toilet or whether it's a day room or anything in between. We've also, as part of that discussion, been having conversations about whose role it is to clean what. I can't believe that nearly 40 years into my career, I'm still talking about who cleans which particular piece of furniture, but we are. But that is something, again, that is part of that general cleaning discussion, cleaning standards discussion. In terms of provision of equipment, it is something that I've personally had a conversation with the head of the service about, and I've asked them to go and ensure and satisfy themselves that the level of equipment that's required, not just in that particular site, but across the other sites in the organisation, are readily available. The other thing that we've been looking at is how can we make better use of our UPV machines, so our ultraviolet light machines, and also our HPV machines, hydrogen peroxide vapour machines. They are a little trickier to use because of the infrastructure that we have. If we were an all single room facility, it wouldn't be a problem. Because, however, the types of ceilings we have in some of our areas, the standard of our fabric of the infrastructure, it does make it a little more challenging, particularly when we're operating at the capacity that we are. So it's a long answer, but I think it's fair to say that there's very active oversight of the cleaning standards taking place.
Okay, thanks, Mandy. And if I could have feedback on the response from the supervisors in relation to equipment before I go back on February the 3rd, that'd be really helpful.
Yes, I've asked for that, so
Thank
hopefully you will.
Super. Well, thanks everybody. Huge thanks to the team, particularly implementing the records so the data is there, all the work that's going on behind this, the deep dives, and is the board happy to take assurance from the report, and also note that the Quality, Safety and Experience Committee is scheduled to receive the full end-of-year report for 2022-23 with triangulated data and ongoing assurance in relation to those areas that you yourself have raised concerns about, Mandy. Thank you. Diolch. Okay, the next item on the agenda, again, Mandy, is the developing our culture of, and Lisa, excuse me, our culture of listening and learning.
Okay, if I start with the staff experience, I'll then hand over to Mandy. So this report's been completed by members of my team and Mandy's team. And what you will see in here, from a workforce point of view, we're trying to demonstrate how we are listening to our staff and learning from their experiences and adapting to how we can provide support. So we have undertaken, in just over 2 years now, 4 very large surveys, a staff discovery report, which we have presented to board, and the second one is starting to be prepared now. We have the Your Wellbeing Matters survey, which is for our nurses and midwives, and the second report has arrived this week in terms of what our staff have told us. We have the staff survey, which is the All Wales one, and then we also have the medical engagement scale, so some very large surveys where we listen to our staff. You'll see on pages 2 and 3 all the different mechanisms that we use to listen to our staff. And just to add one extra thing to that. We've mentioned industrial action earlier today in terms of impact on patient care, but actually there's a huge impact on our staff as well. You know, they came into a profession to care for individuals, and it's not a decision that's been taken lightly. So our staff wellbeing service have created an information guide for staff who are finding themselves very conflicted at the minute. So we are providing a very responsive service to what we hear from our staff. So to add to that, we listen through the formal and informal routes, and we also have a monthly survey whereby we survey 1,000 members of our staff. Goes out via email and text messaging. People who use our staff benefits app also get a reminder on there, and we do a temperature check of just how people are feeling within the organisation. The aim of that is that within 12 months everyone would have had an opportunity to give us their views. So that is coming up for its first year now. You will see that we talk about our Working in Confidence platform. So it's a new system that's been introduced. There are a number of people that kind of sit behind that system. So a member of staff can raise any issue anonymously. They can then either choose who they would like to respond to their query, because some people will choose to want to speak to someone that they know. Others don't want anyone to know anything about the details. So we will then select who is the most appropriate person to respond. And then depending on what the issue is that a member of staff raises, we will then enter into a dialogue with them, and occasionally we'll meet with them. So we do get to know who some people are depending on how they want us to deal with their issues. So that's going really well. We've had 35 issues raised on that site, and 26 have already been resolved to date. Some individuals have said they've had concerns for years and never felt able to raise it. So this is a really positive platform for our staff. We have introduced thinking of leaving surveys. So we've talked about exit interviews in the past. Why has someone left, or when it's a bit late? So we've now got, are you thinking of going, and is there anything we can do to influence your decision? We've had 192 responses to date, so people are using the platform to talk to us about what their concerns are. Our respect and resolution policy, so it is an all Wales policy now, but the idea is that we try to resolve as many matters that staff have as informally as possible, rather than reverting to a formal process, because once you enter into those processes, lines start to get drawn between individuals. So it's the sit down, let's have a cuppa, let's have a chat, let's see how we can resolve the issues. We have a number of groups that we've established with our workforce. So we have our BAME advisory group, we have champions, we have a specialist, associate specialist and specialty doctor forum, so that's our SAS doctors. We have a bullying and harassment group, which is a subgroup of that BAME advisory board. And we meet very regularly with our trade union reps, so we meet every week with our county leads and our health board partnership forum lead. And we have our regular forums in our counties and for the health board. We will have listed on page 4 as well what we have done when we have heard from our staff, and we've attached at the back as an appendices all of the outcomes of that. So people have asked this is what we've done, these are the number of people that have engaged in all of the work that we have. Our next steps link in with our planning objectives, so that second discovery report. And I know we'll be having a conversation with all of you around how do we start to reach perhaps different people who wouldn't have engaged in the first report, and are there specific things that we want to find out from our staff? So we'll be asking for your views on that. Our people culture plans are developing, so our OD practitioners are out in the services now. They are working very well with our managers, and we'll start to see what each of those services need to focus on to support their workforce. And then finally, our leadership development pathway. So we have a new programme that's been launched this year for our aspiring future leaders, and making sure that we appoint everyone with compassionate leadership who understand that supporting our people is the most important thing. We support our staff, they support our patients. So from a workforce point of view, that's the content of that report.
Thank you, Lisa.
To Mandy.
Okay, so we can't deliver great care to patients without great staff. So the work that Lisa's team have been doing is integral to ensuring that we have great experience by our patients. and listening to our patients, hopefully already as the board's discussion has gone on this morning, we've been able to hear about how we receive feedback, how we listen to what patients tell us, and that hopefully has been writ large through the patient experience report. But you'll see on page 7 again the variety of mechanisms that we use to capture feedback, to listen to what people are telling us. And of course, there's always the face-to-face opportunities to listen to our patients as well. I would like to call out on page 9 the work of the community outreach team, and particularly trying to reach out to those people who are vulnerable, or those people who perhaps are more difficult to reach, are minority communities and others. So I think that's a really important step, and that is going from strength to strength, and we will continue with that work. The other thing that I want to identify, and although this is predominantly for our staff, the Speak Up Safely work that we've instigated around the Speak Up Safely champions, I work very much on the say something, see something, say something approach. And if they are concerned about something, as Lisa has identified through the confidence platform, then we can do something about it. And we do hear staff talking to us about what they've seen that isn't quite what they expected to see in terms of patient experience, patient care, and that enables us then as an extra way of acquiring information about our patient experience as well. So lots of work going on, as we've already talked about, in terms of how we can go about listening to what people are telling us about their experiences. And I hasten to add, not just in the hospital environment. And I think that's really important, because we can sometimes presume that we're only doing it in the inpatient area, and our young people also have a voice as well. In terms of the work that we're undertaking to understand the patterns, the trends, the themes that are emerging from the work that's going on both for our staff and our patients. Obviously, we've got our listening and learning subcommittee. We've got our learning from events activity that's going on as well. How we're sharing that learning across the engagement and experience group. So all of those are sources through which we can take the intelligence that we're getting back from both our patients and our staff as well. The Improving Together programme is something that I've mentioned earlier, and I know that Hugh has mentioned it as well. That is something that we are driving forward with our operational teams to make sure that we can bring together all of the elements that enable us to give great service to our population. Our performance dashboard, our safety dashboard, they are all helping us to have that intelligence as well. So lots going on, I think, both from a staff and a patient listening perspective, and I think Lisa and I will take questions.
Thank you both. Questions, comments? Anna, Judith?
It's really great to hear all of these different things that really, I think, show a step change in the way that we are being proactive around supporting our workforce. But I'm reminded, Lisa, of that expression, people don't leave their jobs, they leave their bosses. And we know that middle managers get a really raw deal in most organisations. They're answering in two directions, and it's a really difficult place to be. Do you feel that of all the different things we're doing enough to recognise their crucial role in supporting staff? And is there anything more that we can be doing to help those managers look after our staff, who then in turn look after our patients?
Are we doing enough? There's always more that we can do. So we have got a coaching network now, and our OD team do reach out to all of our middle managers and senior managers in terms of how are they okay, particularly in the times that we're in at the moment. I know there are regular telephone calls with people saying, I'm just checking in on you. So we are doing that. Leading Experience and Awesome People programme, I think it's Experience Leap. Is our programme was launched in the last few weeks, which is around our band 8A and above managers, so our service delivery manager level and above, who want to be future aspiring leaders as well, to support them in terms of how do we help them with the listening and the engaging piece of the work, not the technical skill. We know they have the technical skills, so this is about the leadership qualities. We have a number of leadership development programmes underway at any moment in time. We've got several people on several different programmes There is also a programme which will also take place as well in terms of personal development. So that again will be launched later on this year for that level. And there is a new management development programme being launched for people from supervisory level up to that band 8A. So we're getting to the next level down now in terms of starting to work with them about leadership, support capability, and also resilience. So that personal reflection and the Making a Difference programme is not only making a difference for the patients, but also how do you look after yourself. So that's a really important part in all of our programmes now. Thank you.
Judith, then Chantal. Thanks, Lisa.
Yeah, thank you. And I'd echo everything that Anna said. I suppose what I think this Thinking of Leaving survey is fantastic. And, you know, you and the team should be congratulated to bringing that approach in. And I know initially the numbers are small, but I mean, if you can stop a number of those people going, that's huge. But it was a bit of a concern that about a third of those people are talking about bullying and harassment as being the reason for going. So I don't know if that is a snapshot or whether that a feel that you're getting. And then something which I hear a lot, and I know we've had communication about a particular situation, where people think they're not being paid on the right level, and they look at other health boards and they say, my job is banded higher. And I know Agenda for Change was supposed to stop that happening, but I know it does. So I just wonder if you think there's some easy wins in any of this that you could be addressed, and then also what your feel is around this. You know, is that third of this survey around bullying and harassment something you would think would be replicated in other areas and with other groups?
It is a recurring theme, and it is a piece of work that the OD relationship managers are working on with managers in terms of talking to individuals about what is the experience, because sometimes the experience, when you go into the detail of it, isn't quite as somebody first thought. However, it is the experience that somebody encounters. So, for example, if someone's been robustly line managed, they will say, I'm being bullied by my manager. Now, how you feel about that process makes it really important that managers know how to handle difficult conversations so that it doesn't come across in a bullying style. So there's lots of work taking place at that. We do hear feedback from staff that they feel bullied by colleagues as well, more than managers, in terms of there are cliques on wards or in workplaces, and it's how we, through the respect and resolution process, have that informal way of how do we build good team culture. So I know Rob Blake's team, the staff experience team, does a lot of work with service areas to what are our common goals, what are our rules, how we're all going to behave. So we're doing lots of work around that. The second part of your question, I've forgotten, sorry.
It's the grading, the banding, this issue about my role's a higher grade.
We do get
Swansea Bay. I get that all the time.
We get that from staff. We get it from Swansea Bay as well, telling us you pay more than our staff. I think that's something that we have seen more of and will expect more of with the financial climate, because people are really feeling the pinch now, aren't they? And people want progression. And I think the latest round of Thinking of Leaving and some of our exit interviews are for financial reasons now. So it is something that we need to be aware of. And when people do raise an issue that they believe their job is banded different in another health board, we do follow that up. There is an All Wales consistency process as well. And the devil's always in the detail of what's in their job description as to why is it different. So we do try to deal with that, but it is a more common thing at the minute.
Okay, thank you.
Chantal.
Thank you. I should know the answer, but I was just asking about the take-up with a lot of those initiatives, given the significant challenges on a kind of day-to-day basis. So what's the take-up in terms of coming to those events, being on the leadership pathway, etc.? Because if we're looking at a very large organization, so, I would want to know what's the percentage of people that are engaging with that particular process. I think my second question was, picking up on something that Judith said. I don't know whether the staff have access to Health Education Improvement Wales Learning Portal, GWECLA, because they have some really, really good resources in terms of how to have difficult conversations, building resilience, compassionate leadership. There's a whole host of resources on that particular portal, plus examples as well, which would be helpful for staff to access whenever they want to.
Okay, so in response, I can't give you the percentage of uptake, but we could do a report to the people committed to give that.
Thank you.
I can tell you that the LEAP programme launched last Monday, and by close of play on Monday, there were 3 applicants. So considering our middle managers are actually very busy at the minute, it is something that people want. So we have seen quite a number of applicants already for that new programme within the first week. And yes, there is access to the HEIW site through our OD team. And as some of our leaders go on our management programmes, there is also a section hidden behind our intranet so that they have learning groups and learning sets.
Yeah.
So they have access then to all resources that they need, but also to be able to chat with each other as well in terms of, I'm struggling with this, can you help me with that? So yes.
Thank you. Derek.
Pardon me. Thank you. It's really a question about how this programme could actually improve our attractiveness to prospective staff. And is this part of the suite of offers that we make? Because we have seen during the COVID pandemic and following it, a number of people have moved into the area for a better life-work balance. So is this really being communicated to prospective staff that this is another type of support that we can give to our staff? Because sometimes, bearing in mind the cost of living, however, taking that out of the equation, sometimes people don't always look at the salary, they look at the work-life balance and what it can give to them. So I'm just wondering how you plan to kind of provide this as another thing that Hywel Dda can offer our prospective staff.
Yeah. So our medical workforce, it's definitely out there because we do hear from candidates who have heard about our new consultant programmes and our medical leadership forum. So that is definitely something that is known outside of the health board. And the second part of the question was raised in people committee when we met last month.
Yes.
And what we have said is that we do need something in our recruitment offer which highlights all of that experience as well. So we are working on that now to start to ensure that it's part of our normal recruitment process as well.
And I could just add as well, I guess the other impact of this in the board, I think you may have said this at the last board meeting, but our retention rates are significantly improved as a result of this. So you've got to have both, haven't you? I think it's important. I think we went from one of the worst in Wales to now the best in Wales. So it is showing it is having some significant impact.
Yeah.
We've got to keep going.
Thank you. Thank you for your report, both of you. I think there's a saying, isn't there, that culture eats strategy. And if we don't get the culture right, well, the rest of the stuff is impossible to deliver. This is my 4th year as chair in this organisation, and I'm really proud, and it's wonderful the way this work has developed to enhance the culture of listening and learning and compassion. In my experience, it's probably one of the most comprehensive, compassionate, innovative and responsive programmes of culture and change that I've seen in an organisation. And I know, you're showing us the data, that it's how it's improving things by listening to all of our staff and to our patients. It's never done, but it's a wonderful, wonderful progress that's been made, so thank you. So the only thing I think on top of the recommendation is that there'll be a report on the uptake of all the programmes going to People Committee. So thank you. So the next item on the agenda is the Cyhoeddus TB outbreak review. Over to you, Phil.
Thank you, Chair. And first of all, just recognised the importance of this review to the population in Cyhoeddus and Llanelli, and I think it is important that I take a little bit of time giving some context and drawing out the important points. The TB outbreak, as we've heard before at this board, started in 2010, so it has been going on over a decade and isn't yet closed. And that's why, jointly with Public Health Wales, we commissioned this review, and it is being discussed at this time in the Public Health Wales board in Cardiff. I think, first of all, it's important that I would like to offer my sympathies to all of those affected by the TB outbreak in Hendy and the surrounding area, and I am sorry to anyone who's been impacted by this review and the TB outbreak itself. The report does identify some shortcomings, particularly in the initial management in the early stages of the outbreak, and points out that some of that was not satisfactory. It also recognises, however, the significant improvements that have happened, not only in the management of the outbreak, in the screening process, identifying cases, but also in the local respiratory services that we have in terms of the management of cases of TB, either active or latent TB. We have written to all those affected with active or latent TB, and there is a number on that letter for them should they wish to contact a Public Health Wales advice line if they need some further support. There is a frequently asked questions section on the Public Health Wales website, which is live at the moment. One of the questions there does direct members of the public to our Patient Support Services website if there are other members of the public who have further concerns about the outbreak. However, if people do have symptoms, then it's important they don't wait for screening and, of course, should contact either 111 or the GP advice line. Symptoms of TB are generally a cough a new cough, that is, over 3 weeks, can be productive, can be with blood, or loss of weight or fevers. But it's important that if, I think, people in Llanelli with those symptoms do seek medical advice rather than waiting for screening. We do, however, have over 400 people that we've written to, who we are writing to again and contacting to ask them to come for screening because that we believe that they may have had some contact with cases with TB. So it's really important that I urge them to come forward for screening. It's a relatively simple procedure, the screening. It just involves a blood test and a chest x-ray, and hopefully will be very reassuring to them. The other things I wanted to say were just a big thank you to the reviewers. The review team, we started connecting with them before COVID. We were just about to start the review as the first lockdown happened. So unfortunately, the review has been delayed because of COVID, but most of the review team were able to stay with us through that COVID period. Also wanted to thank Public Health Wales for the way they've worked with us on this review. It's difficult to do a joint review between organisations, and wanted to thank Professor Menkaur, who is my counterpart in Public Health Wales, but also their team. But the biggest thank you, I think, is to our local public health team and our respiratory team, who have worked so hard to improve the services in recent years. And we do have quite small teams, and it's quite tough for them. But they're doing some excellent work, and that's recognised when you read the report. The last thing I wanted to say is, in terms of the recommendation, I wanted to suggest we might go a bit further in our recommendation that's in the paper. I was going to suggest that as a board we accept in full the recommendations of the external report, that we support the attached outline action plan, and that we request that a detailed action plan be taken through our Quality Safety Experience Committee. But I'm happy to take... There is other detail, but I recognise that need to give time for some questions.
Thank you, Phil. In relation to the detailed action plan being received at Quality and Safety, would that be the detailed actions that we as a health board will be undertaking, or will also include Public Health Wales and Welsh Government?
So I'd anticipate, so it would certainly include our action, yes, which is action 4, but I'd expect to take updates on the other all 7 actions,
thank you,
recommendations.
Yeah, thank you. Can I open it, please, to questions or comments from board members? Sam?
Thank you, Chair, and thank you, Phil. I think as a Community Health Council, we welcome the report. I'm not seeking to give any critique at the moment because we're not clinical, technical experts on health protection, etc. But what we do know is that there was some considerable upset in the community, particularly within some families, and our own complaints advocacy service has been involved in those over the years. So just we welcome the findings and we look forward to being part of that action plan scrutiny as it goes through quality and safety. So that was all, Chair.
Thank you. Joe, would you like to add any comments?
I think just to echo what Phil said, accepting the recommendations, I think echoing thanks to our team who has, oh sorry, I'm not speaking to this, who have done a huge amount of work, not just around Cloyne Hendy, but obviously more recently around our response to those seeking sanctuary locally from Ukraine as well. So that team has just stepped up hugely over the past couple of years. Again, to echo Phil's points, we've got a really excellent public health registrar working with us at the moment. So she's working across Haldar and Public Health Wales. She's been involved in the outbreak and the outbreak management over the past several years, and we'll be working with her to draft the detailed action plan for Queesiac. So we'll be taking that to the next Queesiac meeting.
Thank you. Any other questions or comments from board members? Judith?
Brief question. I accept what's been said about developing the action plan, but clearly there are actions here where we have no idea what the dates are. And I'm just conscious, well, I suppose my question is when will we and when will the public know when those actions that are with Public Health Wales and Welsh Government be confirmed?
Yeah, I think in terms of the Welsh Government action, the Chief Medical Officer has written out this month to all health boards and other health organisations an update on our approach to management of TB. Not only, it did particularly focus on the management of TB in refugees, particularly from Ukraine, and gave some really helpful advice. It also indicated a route map for how the national guidance for TB would be produced. And there's an important meeting this week, this month, which presumably is this week, about this, where I think timelines will be discussed. And I think there's a recognition, as much in Public Health Wales and Welsh Government, like us, of the importance of these actions, and I don't expect it to be protracted. So I think we'll when we have more information, we will commit to bring it to Quality Safety Experience Committee. And I think, given we're a health board, we will be seeking that clarity for our population.
Okay, thank you. Thank you, Chair.
Any other questions? Thanks, Phil. On behalf of the board, may we also collectively offer our sympathies to those people who've been affected, and our apologies, particularly in the early outbreak of the TB. And again, a thank you to the reviewers and Public Health Wales and our local team. It's assuring to hear the efforts and the services that we do provide at the moment are much improved. The board happy to accept the recommendations in full, supports the outline action plan, and that detailed actions will be considered through quality and safety. And if we could also keep asking for detailed timelines within that action plan, both from ourselves but also from others in Wales, that would be really helpful. So thank you very much, Diolch. If we can now go on to the next item of the agenda, which is the Transformation Steering Group update. And Steve, that's you.
Yeah, thank you, Chair, and I'm pleased to be able to bring this update. I'm conscious I haven't brought a formal update to board actually for some time now around our work on new transformative ideas, although I would reflect that many of the papers that have come through board over the last year have had elements of transformation in them as we've been going through them. It is probably fair to say in the specific work of the Transformation Steering Group, that progress has been slower in the last year, really partly due to the pandemic, and we were still dealing with that, as the board will recall, in the early parts of 2022, and then the ongoing pressures in the system to be able to engage with people, to be able to generate these transformational ideas. However, there are three key areas where I think we have made really good progress despite that. I want to slightly keep our powder dry on the first one, which is the digital transformation programme. That will be something which will come to board relatively soon, now imminently. I saw the first cut of what I think is probably the most ambitious, awe-inspiring digital transformation plan just before Christmas, and I had a second cut this week. The executive team will be seeing it next week, and then we'll be bringing it in for some board discussion. But some really very positive stuff, and they're being led by the Director of Finance, but actually engaging with a huge number of our organisation as well in the development of that. So I won't say much more on that other than watch this space, and I think there's some really exciting conversations to come on that. The Medical Director, equally excitingly, has been working on our social model for health and well-being ideas. So the board will recall when we established our strategy at Healthier Mid and West Wales at the end of 2018, we described an ambition to become an organisation which was set upon the foundations of a social model for health and well-being. But I think we acknowledged at the time, both formally in that strategy and beyond that, that we weren't entirely sure what that meant. That there were probably elements of it that we understood, but there were all sorts of things that we needed to start to think about to really bring that to life. So the Medical Director's planning objective was to have a process in place that could start to generate some fresh new ideas for us to make what would be a very radical change for our the way in which we approach delivery and support for our local populations. And he's been ably supported by Baroness Rennie Fritchie in that work. So there's a number of pieces of work that have come together as a result of that over the last year. The conversations with a purpose that the Baroness and the Medical Director have been holding and starting to get some real insights from the synthesis of those ideas. The formal, more academic, systematic literature review that's been undertaken, and today a proposal around our first new planning objective in relation to taking this model forward, planning objective 4U, which I think I'm looking for board ratification for. And also the paper does set out a proposal that we have a board seminar probably in the spring where we can explore this, all the products of all of this work in more detail with the whole board. And we'll also bring in the planning objective that Joe holds around health inequalities, and we'll have a more broad-ranging discussion about actually where we might want to go next with both of those planning objectives. And then the final one, which I've been working personally with Angela Burns, is on a process that we've called Your Health Matters. And I think although where this started might not be where it is now evolved, or where it's evolved to, it's really very much become a process by which we are trying to engage with perhaps the part of the population which maybe we don't engage with the most, which are quite often the working age, busy mums and dads in our local communities, to really understand from them how we can make our services better. So it proved quite challenging in the early part of 22-23, simply because getting into organisations when there was still social distancing and infection control concerns meant that was difficult. But we were able to do some of that. We were able to pilot with Bluestone, and I think the Bluestone trial, which I was at both events with a wide range of their employees, was a really interesting insight into how it feels sometimes to be at the receiving end of what we deliver, and how difficult that can be when you're juggling work and home life. And a number of things came out of that. One was just the huge appreciation they had actually that the health board went to talk to them. That was probably something they hadn't experienced previously. But a number of opportunities for our mental health team. Mental health seems to have been a very strong theme from everyone we've talked to. How do we support people's mental health and well-being in these difficult times. So the development of things like trusted advocates within Bluestone are now being is now being pursued by our mental health team. That led us to an organisation that I personally hadn't heard of at the time, but we've now set up more solid links to, again, through our mental health team, the Get the Boys a Lift group down in Haverfordwest, and looking to see how we can work better with them. They provide a sort of drop-in, very informal counselling-based service for people in the local area, and we're looking to see how we can, as an organisation, help to support them more systematically. And there are a number of other organisations which now we are able to engage more systematically, who we're looking to run this programme with over the coming months. And I'm meeting Angela tomorrow to talk about the next one that we'll do that on. So they're really good to see this progress that we're making. However, I think it's probably fair to say over the last year there's also been an opportunity for me to think about how we might refresh our approach to transformation as we go into 23-24. The acknowledgement when we established the Transformation Steering Group was it is very easy for organisations like ours to fall into groupthink, if I can put it that way, that we think about solutions in terms of our knowledge and our experience. And the Transformation Steering Group was really an effort to try and ensure that we could bring in alternative thoughts, whether that's from our staff, from our local population, or from what might be described as thought leaders in particular areas. I think it's, as a group, it's quite difficult to maintain the energy around that. And I think it's also, on reflection, a risk that I think the board itself should be much more driving this agenda than perhaps a separate group, albeit there were some significant board members, including the chair, on that group. So I haven't yet finalised a proposal for the future, but I have suggested in the paper I'd like to bring something back in March. And my thinking at the moment, and I'll be happy to have offline conversations as this sort of idea develops, is that we use our board assurance framework much more as the engine which will drive our thinking about what transformational ideas we might need. So board assurance framework essentially made up of two elements for me. One is our strategic objectives and how we're measuring our success around those, and the other are principal risks that might stop us from achieving those aims. As the board uses that through the year, to have a structured part of the discussion about, well, if one of our dials is not moving in the right direction despite everything we're doing in our planning objectives, do we need to bring some fresh thinking in, some fresh ideas? Who's doing this well in a different industry, in a different country? And for the board to essentially procure some insight into that. And that could be from big thinkers, or it could be from our local population, or indeed our staff. So that we drive our boat going forward through the board assurance framework, using transformation as a way of generating new ideas and keeping us off balance. So I haven't written that up yet, and I'm happy to have conversations offline, including with the chair. I haven't had a chance to talk to you yet, but I will bring something back in March.
Thanks, Steve. Thank you so much. I'm going to open up to any questions or comments. Chantel?
Just one quick question around, because earlier on we talked about the 77 million opportunities. Does this particular agenda, in particular in terms of transitioning to a kind of social model, does that 77 million opportunities feature heavily within that?
Yeah, that's a really good question, because actually it sort of does, and it does in perhaps less obvious ways than just you could simply see it as a line, a transformation will deliver X. But certainly the digital strategy will be able to describe to us maybe some ways in which digital can help us get at some of that 77 million. From a social model for health and well-being point of view, if we can realise the ambition around that, essentially around how we help communities to stay resilient, stay well, to look after each other, that will drive some of the benefits from demand management. So at the moment, our service being there to fix people, this is much more about how we can keep people well and not need to go through that. So whilst you wouldn't see it directly, the efforts that are coming out of transformation, because it's really driven by our strategic objectives, which of course sit at the heart of what's in our opportunities framework, they should be driving us in the right direction.
Thank you very much.
Thank you. There are a number of people who want to come in, and I'm just going to ask you all to keep your questions concise, please. So it's Paul, Ewan, Phil, and then Jill.
Thanks, Chair. Yes, just quickly, Steve, is it your intention that the 2 appendices with this report will form part of the documentation that will go to the team undertaking the clinical strategy review?
That's a very good point, Paul. Yes, I think it's a short answer.
Thank you.
Let's fulfil the Chair's brief.
Okay, thank you. Ewan?
Yeah, no, really welcome in terms of the continual engagement. I think, you know, from with my community's hat on in the third sector, it's really important. I think there are a number of opportunities currently, perhaps, which we could look at as Hywel Dda. For example, obviously we know in Pembrokeshire, for example, there's the Keep Warm, Keep Well scheme, where we've got a number of warm rooms across the county. I mean, let alone last Friday in the Crymych warm room, 47 lunches, free lunches were served to the population. That was just on a Friday, and I know the numbers are increasing as well. So I'm just concerned that when we're talking about later engagement, perhaps in the spring, there's a ready-made opportunity with people who are accessing schemes such as warm rooms across the 3 counties, and possibly those are ideal kind of, you know, places where we can engage to find out what they want in terms of service provision as well. But welcome in terms of, as you say, Steve, when you went down to see Get the Boys a Lift in Haverfordwest, you know, they provide a fantastic service, but I think there are other smaller community organisations alongside them as well, which perhaps we need to kind of focus in on, who perhaps don't have the profile but certainly have the impact. And again, be happy to work with colleagues to make sure that the right organisations get to our table to actually get their voices heard.
Thanks, Ewan. And I'm sure Alwena will connect with you on that as well. Great ideas. Phil?
Yeah, I was just thinking about Chantal's point about how does it link to the 77 million. I mean, we were really clear that we've got a very medical model of health and well-being. And all health institutions do, really, across the westernised Western world, certainly. Within that means if you medicalise an issue, it probably will cost more. And a more biopsychosocial model, if we move towards a more social model of health, then we do have the community resilience that Steve, our Chief Exec, was talking about, then it's a much more health promotion, well-being promotion approach. And the answer to many things are within communities. And I think we need to remember probably that the medical model is so deeply ingrained within our organisation's psyche and culture, and therefore in our staff. And we could say we're indoctrinated in that sort of medical model of health because we train people in that model, that it's going to take quite a lot to shift that. And so we shouldn't pretend it's going to be a quick fix that just suddenly tomorrow, if you just give them a page to read, that then they'll get it, and then suddenly we'll be able to understand how we work with communities as a health board, because I think we're quite a long way off that at the moment. So still a big challenge for us, but I think these reports help us take the first steps.
Thank you very much.
Thank you. I'm going to bring in Jill, Anne, and then Hugh.
Thank you. And I guess mine was a similar point to you and really. We've got significant connections with our communities through our clusters and our communities. We've also got a population needs assessment, and then we've got later on in the statutory partnerships report again reference to our PSBs and the wellbeing report. So I think we've got lots of information there and connections with various parts of the communities that I would want us to make sure we're utilising as well, so that you know, we've got those opportunities ready to be there. And even when we had the event that we were picking up later around Solva, we had 249 people that turned up around specific issues, but they're very much talking about their local needs. And I think we've got to maximise the opportunities when we're going out to talk to people even about future hospital, etc. There's a wealth of information that we can pick up from communities in those events, because the conversation is much broader than the specific issue. It's very much about what they need in their local community and for them and their families.
Thanks, Jill, and what they want to provide themselves as well. Thank you. Anne and then Hugh.
So it's pretty much reiterating what Jill and Ewan said, because there is smaller, like Give the Boys a Lift, but there's smaller groups which, like farmers, have a group which deals with loneliness and suicide. We've got Megan's Wish for youth and teenagers. So if we could incorporate them into our discussions, like going to them rather than asking them to come to us, it would be really good.
Thanks, Anne. Hugh.
Chair, thank you. I'm just very conscious of the conversation we had earlier around the financial outlook and the challenges that we face organisationally. And there are frameworks that we already have in place. We talked about value-based healthcare earlier, and the direction that we're going in certainly would be backed by those frameworks and the outputs we're seeing from those frameworks already in terms of moving into a more preventative space. But I am conscious of the risk of scope creep in terms of what the health board can provide within those overall constraints. And there's going to be a challenge for us, particularly as we get into this area of measurement and measuring the impact, being clear on our evaluation. It's not going to be a one-size-fits-all. We are going to have to be very clear with our partners that with resources comes a robust evaluation method, and we need to demonstrate the impact before we can mainstream any of those investments.
Steve, thank you.
I think the Director of Finance makes a very good point, which I won't disagree, but I do think there is something for us, and I think this particularly came through the work that the Medical Director and Baroness Fritchie undertook, which is in trying to support particularly very small organisations. There is a danger that we are so evaluative that we have to prove the bang for our buck, that we can crush the intention. And Baroness Fritchie talks about the halo effect, that sometimes we have to guard against that, and we're going in on the basis, a bit like our apprenticeship scheme for staff, on the values and the ethos rather than the evaluation framework. It's an ongoing challenge for an organisation of this size with the accountability and scrutiny that we get. But I think therein lies our challenge around how we change our system. So I think we've got to try and keep the balance.
And there are many things that we can do that are not financial. Opening doors, removing barriers, connecting, enabling. Phil?
Yeah, it is tricky, as Steve says, because we have quite a mechanistic approach to measurement, but Hugh, of course, as Director of Finance, is right that we are held to account for the pennies that we spend. So how we bridge that is tricky when it's difficult to measure the impact of an intervention within a community. But as Chair says, a lot of this, when we're discussing in PSBs, is, when you look at our organisations, should be about sharing resource. And it isn't necessarily more money. And some of it is about enabling communities to be more resilient. And so there's a lot of it that is about sharing and isn't necessarily asking for lots of money. We're just, I just think we're still in quite the early stages of it. So it'd be difficult for us to suddenly say we need to do that. And we do need to be careful as a health board not to crush things and try and take charge of everything. And when you think of the social model of health and well-being, you start thinking, whose model is it? It's not the NHS's model. It shouldn't be. It's like for our communities.
I think that conversation, going away from the recommendation, can we also give consideration where we, I don't want to confine it, but where we do discuss in more detail the ideas that are coming from the social model for health within the context of our board. Because at the moment, we haven't got a talk in place properly yet, though we're signed up to the principle and we've got the research. And you've just invented, in my mind, a new word. Instead of indoctrinization, it's indoctrinization. We've got to get away from this doctor focus. With all due respect, Medical Director. Okay, so is everybody on that basis and the rich discussion happy to accept the recommendation going forward? Thank you. Thanks, Steve and Phil. So the next item on the agenda is the financial report. Over to you, Hugh. Bearing in mind that we have had a very good discussion previously in this board. Diolch.
I will take that in, Chair. Thank you.
Thank you. Good, nice answer.
Yeah, there are a couple of things I do want to pick up. And firstly, just to provide assurance to the board, and it's confirmed in the letter, that Welsh Government have agreed to the cash request that we put in, which is a relief for us, and hugely supportive of us, and a recognition perhaps of some of the challenges that we are facing. So we asked for 52.3 million to see us through to the end of the year, and that's been provided. It's incumbent on us now to manage within that cash envelope, and that is in itself a challenge. I would say that, you know, the risks that we've seen in the system when we met 2 months ago have not diminished. You know, there are still significant cost pressures that we're seeing in the system, and despite good work in bringing additional supply of staffing in, particularly overseas recruitment, we are still seeing a significant reliance on agency staff. And that is only natural when we're in a system that is running in as challenged a space as we are. So our forecast for the end of the year is 59 million. I would say that is more challenging now than when I sat here 2 months ago, and the risks to delivering that are certainly more challenging. And the pressures, continued pressures in urgent emergency care, talked about before, but in particular primary care prescribing, really challenged. And there's a mixture here of cost pressures through the CAT-M, the increasing costs that just get passed through to us, but also another element, which is the no cheaper stock obtainable, NCSO, which is a recognition of supply chain challenges. Difficult to work out how much of that is Brexit, how much of that, because that does have a very significant ongoing impact, and how much of that has been demand that we're seeing across the system, across the UK, not being met by supply, but nonetheless a challenge for us. Annual leave accrual as well. I just want to emphasise that clearly staff are working hard, and I am worried about not taking annual leave, which means that our annual leave accrual, which we have anticipated will come down, may not come down as we anticipate. So that gives us an additional pressure, although I would say that the policy that we've got now is very clear that we can carry forward the maximum of 5 days. I'll just finish with just mentioning TI as well, targeted intervention, and there are 4 areas that we're working on very closely with the Finance Delivery Unit. Firstly, I'd say really welcome the dialogue we're having. It's a very mature dialogue. It's a recognition and a curiosity into the issues that are driving our expenditure, and a recognition that this is not necessarily, which is slightly different to the previous TI framework where there were challenges within the finance department. It's now a recognition that it's a financial issue, not a finance department issue, which has been a very welcome shift in emphasis. But there are 4 areas. Firstly, understanding what the opportunities are from the increased expenditure, from bringing some of that COVID expenditure within our core. So we'll need to get into more of the understanding of the 25 shift to 62 and then on to 80 million that our underlying deficit is at now. Secondly, our opportunities framework, making sure that's live and embedded in the way in which we work, and it is indeed. So this is just about the process of providing assurance on that. Secondly, around the organisation's delivery framework, how we collectively, as a board, as corporate teams and as operational teams, focus on the delivery of issues at hand. And then lastly, our financial management arrangements that we have across our governance framework and within the team and with our directorates. And you know, that is certainly another area that is very actively being reviewed by us. The assuring thing from the TI intervention is that none of this is a surprise to us. We know we've got work plans that we're already working on in this place. So perhaps different to the previous framework that we're in, this is all in line with what we know we need to do anyway as an organisation. We've got regular touchpoint meetings with Finance Delivery Unit then and Welsh Government. And I would say that even though we have Sustainable Resources Committee every other month, we have a touchpoint meeting with the Chair and Vice Chair of SRC in between those months. So we have a continued monthly dialogue with key individuals in our governance space and with government. Chair, there's only one thing that needs approval, which is the scheme of delegation change in CHC. That has been through SRC and has received scrutiny in that space, and I don't particularly intend to present that, but if there are any questions, please do ask.
Thank you, Hugh. Diolch yn fawr. Any questions, comments on the report? Winston?
I'll make a comment on the report, which is that I think it's what he's described transparency of our forecast for the year end. I'm surprised that the December position wasn't worse, actually, because if you think about inflation rates in December, in about 10% year on year, and also the industrial actions as well that we've seen in December. So I thought it's quite remarkable that we've stayed with our forecast to that degree. Question in relation to industrial action, do you anticipate here that that may have an adverse impact on our year-end forecast in the months to come? I know it's a bit of an unfair question because you can't predict when that will be and which groups of staff. But I think it's fair to say that we'll have a degree of risk around that, in a sense.
Chair, absolutely. In terms of our forecast position, there is a risk arising from it. Clearly, when people go on strike, they are not entitled to pay in the same way that they would otherwise be. So there is a risk in that direction as well, but that gets offset then by the impact that that will have across the broader system, particularly in planned care, where we may need to put additional activity in order to maintain on track. Now, they are choices for us to take, and as we work through the impact that this has on us over the next few months, we will indeed need to take those choices. What we're seeing is, just to respond directly to the point about forecasting, is that our forecasting at a macro health board level is fairly consistent. There is too much variability within each directorate at the moment. So there is, in the detail, too much variability that when you add it all up, coincidentally, they end up kind of offsetting each other. But the risk is therefore there at a detailed level, and we need more robust understanding and a better understanding, which I very much hope that the Directorate Improving Together meetings will provide us alongside the performance and the quality and the safety.
Thank you. Thank you, Hugh. Any other questions? Okay. I think on behalf of the board, I'd like to thank the Welsh Government for the additional strategic CAS support. And is everybody happy to accept the recommendation, including approving the scheme of delegation changes in respect to continuing healthcare? Thank you, Diolch yn fawr. Okay, the next item on the agenda is the Integrated Performance Assurance Report. And Hugh, that's you.
Cadeirydd, diolch. Very conscious that there are significant areas of challenge for us highlighted in the report, so I won't go through each element. Particularly conscious of the issues being faced now across our urgent emergency care system, and the staff and patients who are, and families indeed, who are adversely affected by those challenges. I was going to just talk about three other areas actually, just to I guess emphasise the impact that our approach in focusing on key areas for improvement has had. And there are three KPIs that I think shine as an example of where focus in areas can make a real difference. The first is planned care recovery. Clearly that's been an area of significant improvement. The second is mental health, and in particular the target of mental health assessments undertaken within 28 days for children, which has exceeded the target now of 80%, and that performance continues to improve. And it's also then above the trajectory that we put in place. So another real area of success. And the third is workforce, to increase the number of nurses and midwives we have in post. Demonstrable work there that has demonstrated a significant difference, and in particular the International Registered Nursing Recruitment Project, but amongst other programmes that are being led by the Director of Workforce. The second area just to highlight then is the challenge that we are facing within cancer, and particular in the reduction of the backlog for cancer patients. And we did see in December that deteriorating, but there are plans in place to reduce that backlog over January and February. And then lastly, just to emphasise the challenge we have got in endoscopy and cardiology weights, which are both showing very concerning trends, very significant concerning trends for us as well in terms of the number of patients waiting over 8 weeks. Those areas that I wanted to just emphasise in addition to the challenges that we are facing across the system. Thank you.
Thanks, Hugh, and I'll bring in Andrew.
Yeah, so sorry. Thank you, Hugh. The areas you picked up were a number of the areas I was just going to comment on from a performance perspective, and you'll be pleased to know if I do it now, I don't have to pick it up in the operational update as well in a few minutes' time. So I think obviously wanted to recognise as well, I think you said this at the beginning of the meeting, Chair, and Hugh's alluded to it there, but I'm very mindful that when we talk about our service and our performance, we are talking about patient experience and delays and difficulties and challenges our patients are facing accessing our services at the moment. And I, you know, as always, very sorry that that's the case, and hope the board take assurance, and they'll take assurance that we are doing everything we can to improve and mitigate that position on a daily basis. So just to pick up a couple of the, in performance terms, the areas that Hugh's highlighted, I think the urgent emergency care system, as we've said, continues to be under significant pressure. It's been an interesting period over Christmas and since Christmas, and I'll maybe pick up some of the escalation issues we've had when I do the operational update, but I think the system in January is feeling marginally better. So in terms of some of those metrics, I would hope to see that we'll be doing better against some of the ambulance handover delay position, despite a difficult start to the month, and also in terms of our waits over 12 hours in ED. So I'm hoping and expecting to see those improve through this month. There are multiple reasons for that. Demand has been kinder to us over the course of the second part of the month in particular. But also I think there are some signs that in terms of the more transformational programme of change we've got and the actions that we're taking around the 6 goals for urgent emergency care, there are some indicators that some of that work is starting to have an impact. So, for example, we've seen somewhere between a 10 and 15% reduction in the number of bed days occupied over 21 days. So that we're still way higher than we would want to be, but there are some signs there that the actions we're taking are starting to have an impact, which gives us encouragement that the plan we've got will start to close the gap. And I'm very focused at the moment, in particular, on the ambulance handover position, because I think there is a significant level of risk to both, well, across our system as a result of that. And in particular, I'm very mindful over the last few weeks of numerous patient stories we've heard and media stories. Some of those have appeared in the media around delays our population have had in the first instance awaiting the response of an ambulance, but then also their experience having arrived at an emergency department awaiting handover to the system and the service. So certainly that's something that from both from my perspective, and I know Phil and Mandy's, that's something we're really focused on trying to have a real impact on over the next 2 or 3 over this quarter. There's something in there that's probably around, it's a leadership challenge and a cultural challenge in terms of our approach, and we have been to Cardiff and Vale just to see what they've been doing over the last 12 weeks, because when you look at all of the data across Wales, there's the improvement Cardiff and Vale have delivered in a relatively short time frame is really significant and stands out compared to every other health board. So we've been there, we've learned, and we're just working through the implementation of that with our teams locally. In terms of cancer, I'm pleased Hugh highlighted the issue we had and the challenge we had in December with our backlog increasing. We had been showing a positive trend until that point. There were a number of factors that played in December that impacted on that position. Some of it was capacity we thought we had secured not coming through. Some of it, a small amount of it was linked to some of the strike action that took place, but also strike action not involving the NHS. So one of the key elements we've had around helping manage our endoscopy demand has been the use of fit testing. Well, that relies on the postal service, and the postal strikes through December had an impact on the timeliness of those tests being distributed to patients on the waiting list and then those samples being returned. So there are numerous issues that play into that. I'm pleased to say, as I sit here today, the backlog looks like we will be much closer to 400 than 500. We were at 579 at the end of December. So by the end of January, we're anticipating being much closer to 400. I can't quite get the operational team to come off the fence today for me. I've been trying this morning to get them to come off with a definitive figure, but it's probably a couple of days too early in the validation process. But they're confident there's going to be a significant improvement in that position, which gets us back on track with the trajectory and the improvement plan we had. And we know that cancer and the backlog reduction is a part of our enhanced monitoring position. The final area I wanted to highlight was just to pick up, because it's a positive news story as well, is the position around planned care and in particular the ministerial milestones that were due for delivery by the end of December. I'm pleased to report that well, there's a few things I'm pleased to report. So the first one is that we achieved the trajectories and exceeded the trajectories that we set out to the board in June. So that's both for patients waiting 52 weeks for an outpatient appointment and the milestone that was introduced in the autumn for patients waiting 104 weeks for an outpatient appointment. We made significant progress on that too, reducing that from nearly 4,000 patients at the time the milestone was introduced to 511 by the end of December. In the context of the 52-week position, on the 1st of April, we had nearly 31,000 people waiting over 52 weeks for a first outpatient appointment. By the end of December, we'd reduced that to 5,452, so over an 80% reduction, which is a significant improvement in the position. We've also, in doing that, I believe we are the best performing health board for those two milestones in Wales, which is always a nice accolade to receive. But also, I find this one a slightly more, this is a more interesting one, which is the most improved health board through the course of the year, which is positive as well in terms of the action we've taken and the urgency and the confidence it gives us in the plans we had, because we always said we would improve, and we've demonstrated that. But also, there's a nuance in the milestone for the end of December, which was it was around patients waiting over 52, reducing the number of patients waiting over 52 weeks in most specialties. And I think it's significant that as a health board, we have the fewest number of specialties left with patients waiting over 52 weeks too. So I think in every sense of those milestones, we've done really very well to deliver that. And I know the amount of time and effort that the operational team in scheduled care led by Stephanie Hire has put into overseeing the delivery of that. It's a real, particularly as you get towards the last 4 to 6 weeks, it becomes a really huge man-marking exercise to make sure that that happens. Finally, we remain ahead of our plan and trajectory as well for inpatient treatments by the end of March, and waits over 104 weeks. So even with some of the strike action that we've had and some of the impact on our elective capacity, that's not impacting that trajectory at the moment. So we're just working through at the moment, as we always do at this time of year, just where we think we're definitively going to land by the end of March, based on what we know now and the actions we've taken to increase capacity, as we said we would through the course of the year, and other known factors that are playing in that might mitigate some of our delivery.
Thanks, Andrew, and thanks you, and thanks for giving us more of the detail. And I think the board would want to join us. Just huge thank you for the amazing effort of the planned care team in not only delivering the promises that were made, but exceeding those promises in these most difficult times. And it's lovely to have some light and delivery and achievement. So massive thank you to you and the whole team for that, Andrew. Rodri.
Just one quick question. I think it's brilliant, looking at good practice, and you mentioned the Cardiff and Vale. Were they doing things much differently to what Cyhoeddus are doing, and how achievable is it to turn it around kind of in the short term?
Thanks for the question, Rodri.
Sorry.
No, it's a good question. No, it's a good question, because it was very much the conversation Phil, Mandy, and myself had when we returned in terms of reflection and trying to think about how it translated into our environments. I mean, I think there were some things there that there was lots there that we did learn, and I think one of the things we learned very strongly, that there was a very, as I say, that it was, the improvement had been as much around leadership and culture towards this as a standard, not as a target, and the way they had engaged the whole organisation in the improvement of that position, as opposed to what can be sometimes seen as an emergency department problem, because that's where the problem manifests itself. I think what they've been very successful at quite quickly is engaging the whole organisation in the ownership of that problem and contributing to improving that position. So I think there's more we can do locally in terms of the consistency of that. I think we've got pockets of it, but we can be more consistent. And possibly, I think the other thing they've done is they've been a bit more protocolized. So they've got protocols very clearly that support that sharing of the problem, which I think we have, but probably not in as black and white fashion as they do. So I think there's certainly some quick work we're putting together that helps to do that. I think the other thing, that, and this is a very valid point, and this is what we're trying to get our heads around at the moment, is obviously University Hospital of Wales is a big site. It's a big emergency department relative to any of ours. Interestingly, it doesn't have any more major spaces than our Glanquilly department has, but there is a bigger site and there is more space and more spaces, if you like. So as you're trying to pull patients through into surge capacity within that footprint, they've got more space in which they can do that. So that's one of the things we're just working through with the site teams, is we don't necessarily have that footprint and physical space or that we could use in the same way. So we just need to think about how that part of it translates. But there are certainly things we believe we can do that can impact on our position. I think since we've come back, we've been pushing with the ops team some of the kind of culture and leadership element of this. And I think there is some early signs over the last week that some of the message is starting to get across. So, for example, and I don't mean to make this sound very twee, because I'm conscious it sounds very twee, but I have banned the word offload now in relation to ambulances. It's handovers is all we talk about now. And we're sort of trying to encourage everyone to self-police us as an exec team and our operational manager peers in terms of the use of that phrase as well, because it's a very subtle difference in meaning, but I'm very conscious that the word offload means to get rid of something you don't want. And we're an NHS service. We absolutely want these people who are in need and sick and unwell to be coming to us. And we very much wanted to receive them off the ambulance and hand them over. So it's just, there's some small things like that we've already enacted, but we recognise there's some sort of process changes that we need to make behind that will facilitate dealing with the times of of highest pressure and demand.
Andrew, is one of the things being cited on how many people are waiting in the community within the A&E department and how many people are waiting in A&E on the wards? So there was a sharing of responsibility for people who are in the whole system. Yeah, that's absolutely what they've done, and I think that's how they've achieved that ownership. And we've started trying to do that locally as well. And I think it's a very difficult concept because we've got some very stretched and busy staff and busy services. When we talk about the amount of surge we've got open over the last month, in terms of spaces, we're talking about something the size of Bwrdd Hospital, over and above what we're, in terms of bed spaces and ED spaces, over and above what we're kind of running as core. So that they are, and we don't necessarily have a significant increase in staff to do that. So they're very stretched. I'm very mindful that there's a lot of pressure and strain on them at any given point of time, and the risk that they're managing on site is really difficult. What we need to do, though, is I think we need to be far more aware of assessing risk in the community for patients waiting for an ambulance or waiting for a response, as we are around the risk of an acuity of patients within our emergency department and our waiting room. And that's the kind of balance, as well as the strain and stress and pressure that our staff are under with the number and volume of patients around them in the department at any given time. So it's how you balance, it's how you get into a conversation with them that helps them to balance all of those issues when they're risk assessing at any given moment. Is now the moment I could hand this patient over, or do I, are there things we need to do first? Yeah, thanks, Andrew. Any other questions? Delith and Anna.
Diolch, Chair. It's leading on from Roger's question and really when we think of Cardiff and the Vale, it's a centralised A&E. And we've got, as Rodri mentioned, the greatest landmass in Wales, and we've got 3 A&E departments, and potentially as well, we've got different and more complex cases coming through our front door than necessarily they might not have got within Cardiff and the Vale. I'm thinking of farming incidents and RTCs, whatever. And the conveyance to hospital times potentially are longer, so our acuity of our patients is worse. So are we also contrasting with a more rural area, such as in Scotland, to think about how they manage that front door potential, that we need to really think about rural medicine and GP and primary care colleagues in how to actually preempt some of those admissions? So I'm thinking about a system-wide approach.
Yeah, and it's a very good point, Delith, in terms of the demography and the nature of the acuity that we need to manage and the need we need to meet. I suppose I would just, in response, make a distinction between the two issues, though. So I think in terms of our transformation plan and our response to the 6 goals of urgent emergency care, the Welsh Government policy document, I think absolutely, in terms of the models we're putting in, we are looking at how does that compare, not just in terms of some of those more urban centres in the UK, but also looking across the UK and worldwide at systems that look more like how they are in terms of, as you said, the rurality and some of those travel times and travel issues and the demography. So definitely doing that. I think I suppose there's I suppose in my mind there's a little bit of a difference between that transformation work, and although it all aligns and meets at some point, there's a slight difference between some of that transformation work and some of the more kind of urgent performance improvement, immediate in the moment things we can do to just help make the pathway and processes run a bit smoother.
Anna.
Thanks, Chair. It's clearly entirely appropriate that we have a big focus on urgent and emergency care, and we understand that's a really complex picture with lots and lots of different moving parts. But there is one other service area with equivalent performance, albeit not on the same scale, and that's CAMS neurodevelopmental services, where arguably that is an outpatient waiting list with arguably fewer moving parts, greater predictability. What is it about that area of our work that is proving so difficult to gain some kind of traction and improvement on?
So in terms of, I mean, I agree with you, Anna, first of all. I share your concern, and certainly in terms of our conversation with Welsh Government and our first enhanced monitoring conversation, IQD meeting a couple of weeks ago, the 2 areas that they pinpointed as, well, 3 I suppose at that point, the 3 areas they pinpointed as having some concern about were the cancer backlog and the fact, and wanting assurance that that was just a blip, if you like, rather than a consistent trend now of deterioration after December. But the ambulance handover position was one, and neurodevelopmental waiting times was the other. I think the most significant challenge we've got around neurodevelopmental services is how difficult it's proving to demand and capacity model that service in terms of the range of different interventions required. And we know that we're in a position whereby our capacity doesn't meet the demand that's coming through the system. So, and even with some of the actions we've taken and the outsourced capacity we've secured, which we reported last board, that still doesn't close the gap between the new referrals coming in, the demand on the backlog on the waiting list, if you like, and the demand that we see every month. So we have sought, one of the requests we've put into Welsh Government is for additional help from the delivery unit nationally to help us work through that demand and capacity modelling. I think it's worth noting that neurodevelopmental services across Wales are a challenge, and the demand and capacity issue is proving problematic across Wales as well. So there has been a national review of that in progress that hasn't yet reported as well in terms of recommendations and the way forward. The delivery unit were coming to spend a couple of days with us, I think it was this week, not next week, to work through some of that with us specifically. So I'm I'm hoping that by the time we get to the next board meeting, we'll have a far clearer position around the gap, but also the actions and opportunities we've got to close that gap beyond what we've managed to achieve so far.
Andrew, the other area which we share in common with the rest of Wales, massive challenges, are those people who are ready to leave hospital or are medically able to leave hospital but are unable to because there isn't the care that they need to enable that to happen into the community, be that from social care or elsewhere. And I just wondered, we heard the initiative from Pembrokeshire County Council via the Chief Executive when he visited Withybush Operation Nightingale to deploy social care to focus on assessments and on enabling people to leave hospital. And I wondered what the impact of that has been. It might be too soon to know, but has it made a difference? And an update on the discussions with our social care partners.
So I think it's early days yet. We're sort of a couple of weeks into that following the visit. I think there are some notable changes. I think the most notable change that colleagues would comment on is there's certainly an increased level of engagement and joint working and support to try and work as a system to try and resolve some of those issues. So that's obviously a positive step. And there's also been a significant movement in terms of social worker allocation in the county. So that was a specific issue that was called out. So we have seen movement both in Withybush and South Pembrokeshire Hospital in terms of a flipping, if you like, of the number of patients waiting for social work assessment versus those waiting for social work assessment. I guess though, as we'll see with this, as you work through the process and you fix one bit, you then get hit with a bottleneck at the next stage. So I guess we're not necessarily, although the social workers have been allocated, and it's too early to, obviously we're 2 weeks in now, so it's still quite early for this to happen. What we haven't seen yet is the increased level of social worker assessment then having an impact in terms of pulling down some of the length of stay and delays in the process that would support the understanding of what package of care is needed and the discharge of that patient. So the feedback is positive, but it's obviously there's going to take some time to work that through. And of course, even once we get the social worker assessments done, the other challenge that we know is still there is how they provide the capacity either through domiciliary care or through nursing and residential care to then meet the need of those patients as well that need discharge. So there's 2 or 3 phases, but the early signs are encouraging, and obviously they'll continue to work together on those issues. I think in terms of the other counties, they've continued to work with us in terms of trying to mitigate the challenge. I know we've probably commissioned more block bed capacity in Ceredigion than we've ever commissioned before as a system, working with local authority colleagues, and also from a Carmarthenshire perspective, we have seen in terms of some of the waits for packages of care, we've certainly seen those reduce over the course of the last sort of 8 to 12 weeks, I would say. So there are some encouraging signs. I think when I look at the data this morning, we've still got as many patients medically as being reported as medically fit as we had back in our last board meeting. The number ready to leave is slightly lower, but that I hesitate to say that's a positive because there's an element of how those numbers dynamically change and move between lists on any given day because it just depends where you are in the process. But there is certainly a sense in terms of the escalation levels on the sites and the system that the position in the last week to 10 days has improved.
It's good to hear, but the challenge that we're all facing collectively is approximately 1/3 of our beds are occupied by people who don't really need to be there. It's not fair on them, and picking up the financial situation, 30 to 35 million per annum, it's costing us as a health board for people to be in a place that's not good for them. And this is a national challenge, isn't it? But it's good to hear, and I really want to thank the initiative let the Chief Executive talk following his visit. Steve?
I was just to say on that, I mean, I think probably everybody was really encouraged with the response that we had from actually both the Pembrokeshire system first and then Carmarthenshire last week. Just to sort of pick up on some of the things that Andrew said, I have offered the Chief Executive of Pembrokeshire Council a further visit to Withybush to start to see the impact. He acknowledged up front that the redeployment of social workers to start to do the social work evaluations, which I think we had about 60 at the time across the two hospitals down there, wasn't going to solve the problem, but it was going to move it to the next stage, and he's working on plans which are probably more knotty around the expansion of domiciliary care and other placements, but he's got some ideas that he wants to share with us on that. But I think the sense of urgency we got from that, I think, was really encouraging. The plan for the local authority around staffing is partly an overseas recruitment drive, and Lisa and the team are providing support and advice given our experience in that. So keen to see where that goes. I think all of this stuff will help in the short term. As Andrew said, you can't see it in the numbers yet. We did a similar walk around of Glangwili Hospital with senior leadership from Carmarthenshire last week. I think what's interesting between the two counties is their problems and challenges, even though they're right next door to each other, are actually quite different. So I think we had some really positive developments around the Home First initiative in Carmarthenshire, which will really help to streamline people out of hospital and into the right level of support. However, the challenge in Carmarthenshire, which I think will probably emerge in Pembrokeshire once we get through this initial stage, is the nature of the community provision doesn't fit the needs of the patients who are sitting in our hospital beds, who quite often have overlapping needs. So the Chief Executive of the Council and myself have agreed a scope, a planning objective, which is being developed. The ideas are now being developed, the response is being developed by a small team from the Council, from ourselves, Andrew involved, our County Director involved, to come up with a set of proposals by March where we can radically change the provision system in time for next winter. Excellent. So I think we've got some real, we'll see where that goes, but we've sort of said don't at this stage, don't worry about the kind of who's going to be responsible for it, how it might work, just tell us what we might need and then we'll work through how we implement that afterwards. So really positive. I think we'll get there with Pembrokeshire shortly after.
That's great. Thanks, Steve, and thanks, Andrew. Judith?
Just add to this really, because we had a discussion at the Regional Partnership Board about this issue, and actually the County Director for Carmarthenshire, as you know, is a joint post with the local authority, who was therefore Jill, presented some issues around the Home First, and I think there's some really big, challenges and questions for partners about taking a model that works and taking it and doing that within your community when you're doing something different. And I was just looking at some figures I've got in front of me. Out of the 916 people discharged from the hospitals in Carmarthenshire, 65% of those didn't have any statutory care or support needs. So there's a real issue about, are we over, assessing people or leaving them so long that they need more than if we can get them home quickly? I mean, there's loads of other figures, and some of you will have seen this because it was a presentation that was made as a round table event. But I think it was very clear from some of the comments that came was there was some reluctance from the people at a middle level to think about doing things differently. So I think engaging the chief executives, again, well, let's say the director, because he's part of this, but to just think about doing something different is a bit of a challenge that we would have internally. But I think, the Minister is very clear. She's challenged regional partnership boards to be the facilitator of this different way of working. We've got some great examples of where things are working. We're not great as a region in translating that and stopping doing things that we're doing now, because that is a bit different. And I know Hugh has been looking at that from the point of view of how we utilise the resources that we are now responsible for that come into the region. But I just think that is another think we really need to look out before we think of lots of other initiatives, because we've got stuff that's working, and that Home First is absolutely critical and really is working. Thank you, Chair.
Thanks, Judith. If I'm going to bring in Mandy as the last
And it'll be a
person.
very, very quick comment, if I may, Chair. I think building on the point that Judith has made and also that Steve has made, the benefit of the visits into both our sites has helped us also focus on some of the improvements that we need to take, and particularly around culture, the assessment, and understanding what the patient, what the individual actually needs when they are discharged. Because at the moment, we are over-prescribing and over-risk assessing in terms of the level of risk for our patients, which is leading to some delays in their discharge. So I think that whilst these visits have ultimately strengthened and will prove to strengthen our partnership arrangements, how we work collectively on that culture of risk-taking in a very healthy and safe way is going to be key to how we move forward.
Yeah, thanks, Mandy. And I think that was demonstrated when we escalated ourselves and we had the community team come in who have a different and probably a more practical skills when it comes to the risk and discharge. So thank you. Andrew, we'll pass on from the board the thanks to the teams, and particularly the Plan Care team. So the board's happy to accept the recommendation. I'm going to quickly take the corporate risk register, and then we've got our Liz Carroll. So I'm going to go from there to 4.8. And then we'll probably have to stop for lunch then, if that's okay. So over to you, Jo.
Yeah, thank you, Chair. So since the report was last presented to the board in September 22, all the reports have been through the committee and scrutinised in detail through there, so I'm not going to go through them one by one. Just to apologise, there is an error in the number table because I clearly can't count. There's been 2 risks reduced rather than 3. But I guess really just to show us how dynamic the corporate risk register is, because if you look at today's agenda and scheduled care, and a lot of the other issues we've mentioned today are all included within the corporate risks which are presented for the board today. There's just 2 to flag though, that since we did present this, the finance risk has changed because we've had confirmation from Welsh Government in respect of the cash assistant, and as Alison said earlier in relation to the industrial action, that risk is quite dynamic, Chair, as well.
Okay, thank you. Thank you for the presentation. Any comments or questions? Board's happy to accept the recommendation and also the assurance that our discussions are reflected within the risk register. So thank you. So we're going to invite Liz Carroll in, and we go straight to 4.8.
Would you like to take an item before?
Yes, please.
Very quickly.
That would be wonderful.
Is that okay?
Thank you, Mandy.
Just conscious of time. It's item, I'll have to go back and check the item number, but it's 4.6, the real-time demand.
Yes. Thank you.
It won't be many minutes. It's really just to highlight the reason why we've brought this here is because it is one of our enhanced monitoring actions. So in the discussion around what more we can do to support flow and improve experience through our services, we were asked to consider further rollout of the real-time demand capacity tool. And I just need to emphasise it is just one of a set of tools that we have in our kit bag to drive improvement around how we support patients to move through our system in a timely way. We have offer of support from Improvement Cymru to support us in 2 of our 4 sites, and that is progressing, and the other 2 sites we're using our own internal improvement resource to actually roll that out as well. There has been some improvement as a consequence, albeit I think it's more multifactorial and specific to the rollout of the real-time demand capacity work, and that is in our pre-midday discharge. So we've gone from single figures to double, but I do think that is not down to this specific tool alone, but rather a variety of different factors. So it's there just for people to note and see that we do have a full implementation plan.
Thanks, Mandy, because when you look at the graph in the report, there seems to be very little change as a result of what this particular tool. In fact, there's a deterioration in one part of the graph. So I was questioning that pre-meeting. Is that coming back, all these different tools, or are we going to continue using that one?
So we have, we've said that we will continue to roll it out because that was the expectation that was placed upon us, and I will be reporting back through the enhanced monitoring meetings that we have with colleagues from Delivery Unit and Welsh Government. But actually, I will be bringing a collated report through that talks about the totality of our improvement activities. So it can be seen in the context of everything else that we're doing.
Okay, and, you know, sorry, very quickly, building on the conversation before about, you know, stopping things that don't work, we will be looking at it through that lens as well and providing the evidence of all the tools. That's fine. Thank you. Everyone happy to accept the recommendation from Mandy's report? Yeah. Thanks. Welcome, Liz, and welcome, Kay. Really sorry to have kept you waiting, but it's absolutely wonderful to see you in person. It's, you know, it just makes such a difference. So thank you for making the effort to come here and the journey today. We're going to go straight to your report, if we may. I think it's item 4.8. Yeah. Andrew, are you going to introduce it?
I'll just say a couple of words and I'll hand over. So it was just obviously to say that we actually started from an exec team perspective the conversation around a sort of transformation and improvement plan for learning disabilities pre-COVID. So it was a number of years ago that we first started this conversation, and obviously the pandemic happened, and that delayed some of the thinking and some of the work we wanted to do. So it's, you know, I'm pleased that we're now in a position whereby we're coming to the board with a first iteration of the plan we've been working on, which responds to my planning objective 5G. I suppose I just wanted to start before handing over just to say thank you to obviously the team for the work they're doing on this, but also to some of our stakeholders, so the Regional Improving Lives Partnership, the Dream Team, and also to Sam and Mansell for the CHE's time they've spent with us on this over the last few weeks as well, in terms of trying to shape and work through the proposals in the paper. So that was all I really wanted to say.
Okay, thank you. Shall I hand over to you? We have actually read the paper. So if there's anything you wish specifically to bring to our attention, please do so.
Okay, so I've just made some notes to pull out some of the main areas, and Andrew's covered some of that in the introduction. So, you know, we wanted to thank you for the opportunity for coming today, because this has been a long time in development, really, with COVID extending that. And the areas we're covering are the inpatient provision, the residential units, and the community LD provision and liaison. So we have, over the last couple of years, I think, brought pretty regular updates along to here and also to the Community Health Council. This paper outlines the various engagement opportunities that the Directorate have been involved with. And Andrew's mentioned those in terms of the Regional Improving Lives Partnership, which is aligned to the West Wales Learning Disability Charter, which was launched at Public Board. I was trying to think what year it was, but it was August, and it was, I think, 2018 or 19. And so we've been working with the Dream Team since that time, who have led and delivered the charter under the co-chair of the regional group as well. So we also worked very closely with Public Health Wales, the 1,000 Lives Improvement Team, in developing the plans and the options that we are putting forward in the paper. So they spent a considerable amount of time with us in September working through, and it gave us an opportunity to really test out some of our thinking and what our planning was. So I think it's quite well informed in terms of having that input. So in developing the future vision of the service, we've been guided by the improvement of the Health Board strategy, as mentioned by Andrew, and the Welsh Government Improving Care, Improving Lives programme. Should have covered that. So we did have the opportunity to meet with the Community Health Council colleagues early in January, and we shared the engagement plan with them at that stage, and they made some really helpful additions which we've incorporated into the plans that we're kind of on that journey of engagement and sharing the feedback sort of along the way. And I think the main area to point out in relation to the paper is the proposal really that we discontinue the inpatient pathway from Bwrdd and incorporate that function into the adult mental health service. So we've been doing that since September 2021, and that was following a HIW review where there was some environmental concerns, etc., about Bwrdd. And during this time, we have enabled the admission requirements for those who have required admission, and what we've seen are shorter periods of admission and discharges back into those environments that the individuals were admitted from, and less restrictive packages of care than we were seeing when we previously had that sort of dedicated admissions unit. So we think that's a favourable experience for people who might need to access the service. And we've illustrated that a little bit in the paper with some examples. The other thing I think that it allows us to do as well is take that debate out of, there's often a discussion when we're admitting people who have a learning disability, because sometimes there is co-occurring mental health presentation as well. And there was often a debate about, well, which service should they be in, which service shouldn't they be in? And I think that often led to delays in admission and getting the right people involved in that pathway. So we've kind of smoothed that discussion out now by having sort of one sort of route in for admission. So moving the service in the direction we describe would strengthen primary care provision and access to physical health assessments, enable the development of a team to work with individuals whose community settings may be at risk of breakdown, so we can put some additional support in where placements are looking like they might be breaking down, and also then to support an early discharge from the admission, you know, if that was required as well. Strengthen the district hospital liaison for those with the learning disabilities, because we'd align those staff now with our current liaison provision in the district general hospitals. And it would enable the development of some complementary roles to enhance the service provision. So we've already got an advanced nurse practitioner who's completed her training and one who's about to start. And we are looking at a sort of pharmacy role with some dedicated input for the LD service to support with some of the epilepsy pathway and contribute more fully to that discussion at MDT level for those people who have learning disability but may be taking other, you know, ranges of medication as well. And we also believe that the improvement, it'll improve our recruitment opportunity with a sort of developing, modernising service. And we're seeing that at consultant level already. So that was all the points I wanted to pull out. Sorry, it was a bit rushed.
No, super. Many, many thanks. Are you okay if we open up for questions?
Yeah, that's fine.
Okay, over to members' questions or comments. Chantal? Anna?
Yeah, I think my concern around is around the fact that these are patients with learning disability rather than mental health issues per se. And whilst I recognise that some patients with learning disability will have mental health issues, I'm just kind of wondering in that particular environment whether there's a kind of separate entity that accommodates patients with learning disability. Because I noticed within the report that that they mix with other patients as well. And I seem to recall that there was an initial report some years ago about the fact that they didn't want that to happen. And the paper doesn't really give us a lot of data or evidence as to why we would want to go down that particular road now.
Yeah, I think Kay will probably need to help me in responding to this. I think the first thing I'd like to say is that the numbers of people where it's purely LD are very, very low. We have an option in here which is about a one-bedded facility that would be retained on Bwrdd. I think my concern around that is that we'd be basically segregation, it would look like segregation, and I don't think that that's the way forward in terms of supporting people who have a learning disability. And we were also quite heavily criticised by HIW a number of years ago when Bwrdd was more of a residential unit and there was a long-term segregation in place on that unit, and I just think we'd be kind of going backward in that respect as well. So I don't know if there's anything. And I think the adult unit that we're thinking of, or which we currently use rather, is this smaller of the adult inpatient unit, so it's based on moral ice wards, which is effectively 9 beds, but they also have the age-appropriate bed there as well. So that one's not always in use, but we've been supporting that function since 2021. So I think that would be my response to that, but I'll let Kay.
Yeah, so we've always had that designated bed on the ward that Liz has mentioned, and I think, oh, can you hear me?
Speaking that thick.
If you just move the microphones towards you, thank you.
Used to microphones, it's okay. So we've always had that designated bed on more lice, but what we know of the admissions that we've had during the COVID period is that it has tended to be individuals with a learning difficulty, and we have, you know, met those needs, you know, on our inpatient facility. We do tend to find that when we've had patients with a profound learning disability, they usually require inpatient treatment, usually in our district general hospitals. So the experience we've had during COVID with T-Brin being closed, you know, we have you know, managed those needs appropriately on the wards. We would like to improve the environments and create autism area, you know, friendly areas, you know, to further enhance that experience. But with you know, the limitations of resources during COVID, we did feel that the needs were met.
Okay, thank you. Thank you. Have you thought of charitable funds accessing that to improve the environment?
Yes, yes, and we've, you know, liaised looking at designs elsewhere. So we've got ideas, but until, you know, we can move forward, but certainly we would access that.
Okay, thank you. Anna, and then I think Paul.
Thanks, Chair. Can I just clarify whether, you know, there's reference here to short-term admissions onto an AMH ward. Would 6 months for this particular client group be considered short-term, and if not, how far adrift from that are we? And I guess on a broader point, you know, sometimes we hear concerns, not particularly here, but more generally, that learning disability services get lost in their big brother in mental health, particularly adult mental health. Do you have, you know, can you give us some assurance that this is not a direction of travel, which means that LD gets subsumed in a service that meets generally a different type of need?
Yeah, I think the very fact that we've sort of had the sort of transforming mental health, and we didn't sort of merge all of that sort of transformation around the range of services that we've got within which the directorate cover. So I think we've been able to take the opportunity to have a particularly focused look at learning disability, as it were, in that sense. I think the challenge and that we will have to constantly bear in mind is that we need to think about the training of the workforce that we've got within the LD facilities as well. And what we've found is that since we've deployed staff to those areas, they've actually applied from those the treatment and assessment LD functions for those posts, you know, that become vacant in some of the adult inpatient areas, and also within the PICU as well, because obviously we have to look at that as a resource that's available to us for supporting our LD client group as well. I think the ability that we have, and we've had to hold some vacancies, because if we go ahead with what our preferred option would be, we would need to train staff really to provide that community resource that I described. And I think the inpatient staff from T-Brin have been deployed of sorts of some of those posts. So we'll have some staff to train, but we're probably going to need a different type of workforce, you know, going forward in the community. And we would anticipate that they would enrich and support the care and treatment plans of those individuals in the inpatient service, so we don't lose that LD connect. And I think, you know, as Kay has mentioned, with you know, neurodevelopmental disorders, increasingly we're seeing that within our inpatient areas more and more. So that wider skill across the workforce is really important, I think. So yes, I think we'd have to be really cautious about maintaining that LD oversight, and we'd expect sort of medical input into those areas where those pathways are functioning, and that has happened. And I think the advancement of those ANP type roles could further support and play a really key role there. With regards to longer periods of detention, as with anybody who may be subject to any sort of part of the Mental Health Act, yes, that can extend. As we know, Section 3 is up to 6 months and can be beyond, and we wouldn't be able, you know, we wouldn't be in a position, I don't think, where we'd be saying, you know, you've had your time, kind of, you know, we'd adopt that same sort of care and treatment planning approach to all individuals. And I think, you know, this is about making the reasonable adjustments for people to access those services that are mainstream in the main. So it's about how we accommodate that bespoke for each individual.
So that national guidance around around short-term admissions to be short-term in nature, that 6 months in line with the Section 3 would be consistent with that notion of short-term.
But I think we should always, you know, I mean, you shouldn't look at it as an up to 6 months. If we could make that a less than 6 months, then of course that's what we'd always endeavour to do, so that we're not leaving people in those environments for long, long periods of time. That would be kind of against what we would want to be doing, yeah.
Thanks, Liz.
Thanks, Liz. I'm going to bring you Paul. He's on Zoom, but
yeah.
Thank you, Chair. Yeah, I share some of the concerns and comments that were made by Anna and by Chantal. In relation to the contents of the report, it's far from clear what engagement and discussion there's been with patients, people with learning disability, carers and advocates in the design of what you're proposing in the paper. In particular, the reference on page 4 of the report, the second paragraph on that page clearly suggests that the discussions which have taken place so far have primarily been with healthcare professionals and managers within the organisation. So we'd like to know a bit more about what involvement there's been beyond people who are working within the health board in the preparation of this plan. You're putting forward 2 options at the top of page 5, but I think it's quite difficult to categorise option 1 as truly an option. I think it stretches the definition of option to breaking point. The comments which are made in relation to the closure around Bwrdd and the chronology of events which occurred tends to suggest that it was the inspection by HIW which was the catalyst for the closure of Bwrdd, particularly as regards to the dates on which the people who were living there were moved out. My main question, I think, is around the issue as to, it's far from clear from the paper as to what the size of the population is that we're designing this service for. It's really difficult to get any understanding of what the extent of the demand is, and therefore what service are we looking to design in order to meet whatever we've determined the demand to be. The only reference to the size of the learning disability population is what I can see as the somewhat proxy measure which is contained in the EIA, where we use the number of people who are claiming DLA or PIP as some form of indicator as to what the size of the population is. And there's no indication from our own data as to what the size of the population and therefore the demand might be for services. From our own information, we know, for example, that we are currently receiving something like 80 or 90 requests for neurodevelopment delay assessments per month, appreciating that not all people who might be requiring a neurodevelopment delay assessment would necessarily form part of the learning disability population, but equally all the people who are having that assessment are not the extent of the learning disability population. There will be people who are not suffering from a neurodevelopment delay who would be part of the learning disability population. So there's those figures. You'd also expect that we'd have data from GP practices, because there's a requirement for them to note the number of people who are on their register who have a learning disability, and from the number of annual medical checkups that have been undertaken. So for me, there's a complete absence really of any meaningful information about what is the size of the population that we're looking to design this service for, and therefore is whatever we design going to be appropriate to meet that demand.
Okay, so there's a few points within that. The first thing I think that we probably need to cover is the closure of T-Bryn was prompted after the HIW visit and the concerns that they had with some environmentally. And that visit was either October or November. We'd just made the decision in the September prior to that we would close to admissions on the basis that there was some fragility there within the workforce. What the HIW visit did was we enabled the move on immediately of individuals off T-Bryn into I think of the 3 individuals, 1 was discharged, possibly 2, and 1 then was moved into an adult inpatient. But the actual decision that we needed to close to admissions was in September and communicated to the local authorities as well at that point, because we recognised that the staffing levels weren't not sufficiently robust in that respect. With regards, so that's to cover the timeline, I guess, in relation to when we actually said no, T-Bryn is now closed.
Sorry to interrupt. Can you just move the microphone?
Oh, sorry.
Thank you.
Okay. With regards to the engagement, I think it's fair to say that through the Regional Improving Lives programme, that's been a discussion in terms of some of the thinking, and our thinking has changed along the way. I think at one point we were very certain that we probably would be reopening T-Bryn, and you know, those have been live discussions that we've had with partner agencies and stakeholders, and I think that the kind of work we did with the Improving Lives in September probably steered us more towards the option 2 that you see in the paper. And you know, I apologise if option 1 looks like it's a bit of a non-starter from the point of view of the paper, but I go back to the point I made previously with regards to that segregation of individuals, where we should really be striving to make reasonable adjustments and accommodating individuals in mainstream services wherever possible. With regards to the population and how we've derived at some of the figures that you might see in the equality impact assessment. So how our footprint was looked at, obviously, and that reference was made to the West Wales population needs assessment estimates, where there were approximately 2,500 adults at age 16 plus, because this is an adult provision only, with a moderate or severe learning disability in West Wales. Now, we recognise there's probably going to be a greater number of individuals, but not at that, not at the moderate to severe sort of end of that spectrum. So, and we also use some of the benchmarking data because we contribute to the national benchmarking as well. So we use some of that data, as well as current caseload activity for the community learning disability teams, which is small in terms of referrals. But I think what we do see is people have to be with us longer for us to get those services in place to support those individuals. So the referrals are smaller, a lot smaller than we'd see in adult mental health or older adult, but people do tend to need to be with us that longer, really, and so we get all of the MDT involvement, etc., sort of in place, that we can provide the best assessment possible and put the best sort of care and treatment around the individual. With regards to the medical checkups, and I probably brushed over it a bit quickly when I introduced the paper, but we do have a health action team, which are currently centrally located, and our aim through this programme would be to redisperse those so that they sit within the community learning disability teams in localities, so that they're not a standalone team in one place, that they become absorbed and part of the community teams, and that their role would be primarily in engaging those individuals with the primary healthcare checks that we know that oftentimes people who have a learning disability don't access to the same degree as, you know, most other sort of citizens. So I think it would be a useful way for us to strengthen that provision with the current resource that we have. And I'm just mindful I might not have covered all the points that Paul has raised.
I think you have actually. Yeah.
I'm just making a quick note.
I was going to prompt you if you hadn't. I think the one issue was the data. So you've outlined the data that you're relying upon. Are you assured that that reflects as best possible the demand?
As best as I think as we can with the information that was is available for us to access. Okay. So we've made reference to the population health needs, and I think the benchmarking as well is sort of,
Thanks, Liz, and thanks, Kay and Andrew. Is the board happy to accept the recommendation, as in the paper? Yeah. Okay, thank you very much. Thanks for making the effort to come here as well. It gives us the opportunity to ask questions and hear you, in person. So, diolch yn fawr. We're going to adjourn now for half an hour for lunch and then reconvene back here at... Sorry, I don't have a watch.
20 past 2. I just want to say 2.
No, 20 past 2. Thank you.
very much. Take
Just, we're going to go straight on to 4.7 paediatric service review. Over to you, Phil.
Thank you, Chair. And so what we agreed on the 24th of November at the last board was that we approved the 3 options for consultation, which was supported by CHC colleagues, and that we would produce the consultation project plan that you see in the documentation. The project plan includes the timelines, indicative costs, and the general approach that we intend to take. Recognising that this is of significant public interest and has been for some time, you can see that there's been a huge amount of work that's gone into this. I think the other two things perhaps to say are that it is a tight timeline. However, we do have reasonable confidence that we would be able to deliver this timeline. And also, you can see that we've taken both a broad general approach to our engagement and also targeted. We intend to take a targeted approach as well with focus groups. There's also the opportunity at the midpoint review to review how our engagement is going and perhaps add in other approaches depending on the learning from the first part of that review. Wanted to thank the CHC for their support along the way with this and the critical role that they've taken, and also Lee and his team for support in producing the paper and the project plan that we have in front of us. But happy to take any questions.
Thanks, Phil. It was one of the issues that was raised by Paul at a previous meeting, and again at the pre-meeting, was the time frame. We've linked it to the new hospital build, which could change, and we haven't got approval. I wonder, would it be appropriate to put 2030 or new build or 2030? Can we do that?
So just so I understand, so the concern is that we've been too specific.
The concern is we're being too specific, and we haven't got approval for the new build, so it's open-ended in effect. I don't know, Paul, you'd like to come in and explain more?
Yeah, thanks, Chair. Yes, my concern is that we're in danger of making a decision which really we're not clear about what the end date will be, or how we will actually, how the situation will actually be crystallised, because we're expressing it as being the establishment of the new hospital network, and we don't know when that is going to be, or even if that is going to be. And so this could just be a completely open-ended arrangement. I would suggest that we probably need some more precision than that.
Yeah, I think what I suppose one point to make would be that I mean, we went through significant engagement and consultation and put a lot of thought into the strategy that we agreed in November 2018. And if we were, and I think we've been quite clear that that was by far and away the option that was felt to be most, would provide the highest quality, safe, sustainable, accessible and kind care for our population, and that other options were felt to be significantly inferior to that. And so if we were to perpetuate this model, whatever model we put in, it would be inferior to the one that we're proposing. We propose in our strategy in 2018. But I do take your point that it, you know, we would need agreement on that, and the timeline we've set as was 2030. I think it would be fair to somehow acknowledge that in our timelines and papers, that it's not within all of our control and it's subject to agreement from Welsh Government and perhaps others.
Yeah, fellow, I recognise all you say, but we're linking this decision to something which is not within our gift.
I was going to suggest, so I guess the concern, Paul, that we might inadvertently make a decision in perpetuity
Yes.
that we think is only temporary because of the nature of the decision making around the new hospital, which as much as we wouldn't want to ever think it won't get built, there is still that possibility because the gift is ours. I just wonder whether we therefore need to maybe clarify that in the event that at any stage in the business development process to support the new hospital, should that process then come to an end, we will need to revisit this decision?
Yes.
Yeah. I think that's a reasonable way forward. Yeah.
Yeah,
Okay,
I agree.
nods around the table. Any other questions or comments on this paper and the proposals? Delith?
Thank you, Chair. It's just a plea, really, that we notice about consultation with our stakeholders. And when we're talking about, I see that we're mentioning children, young people, which is great to see. But are we missing a trick with our educational establishments and our youth groups? Most probably you will have this in train, but we've got captive audiences within our school and they do have regular meetings. So I'm just, because I noticed that there is a communication timeline, but we need to really think about how we do really engage with our population and hear the seldom heard voices as well.
Alwena?
I was just going to say, thank you, Della. Just to reassure that we will be doing a thorough stakeholder mapping exercise as part of that, and we have already had some of those conversations around, including some of our seldom heard communities, and exactly how do we pull in the voice of our younger population and make sure that when we do consult and engage, that it's in a way that they can understand as well, so we have a meaningful conversation.
Thank you.
Thank you.
Thank you. On that basis, the board happy to approve the consultation project plan, including the scope and mandate and timescales, and the commencement of the detailed consultation planning. Yeah, thank you, Phil. Thank you very much, Lee.
Thank you.
Okay, I'll go back to the. Is there any other? Yeah, I will do that because Phil has to leave early for other compelling business. So we do critical care review. Yeah. Thank you. And that's over to you, Andrew. 4.5 for members. Yeah.
Oh, I thought Phil was going to take over that.
It's a partnership, Andrew.
That's okay. So yes, I'm conscious you'll have read the paper. So I think I guess the key points I wanted to pull out are we committed to bringing the paper back to the board this month when we agreed in September originally, I think it was, to put in place a temporary change in the service model or the patient flow anyway from for our level 3 critical care patients in Prince Philip to Glangwili Hospital. This paper provides an update really in terms of where we've got to with a number of the actions we've been trying to take in terms of recruitment to make the consultant rota more resilient. And I guess we were also very conscious that one of the questions put to us at the last board meeting was the fact that we needed to probably start signalling whether this was a temporary change or whether we needed to have a wider conversation sooner rather than later on what the sustainable service model would be if the actions we're taking don't appear to be resolving the situation in the short term. Before I just touch on that, one thing I do hope the paper does provide assurance on is the fact that on the review of all of the data and the information around outcomes of the transfers and the process that we've had in place to transfer patients, there's been no harm caused to patients as a result of the interim arrangement we've had in place. So I think, and the numbers have been a lot lower than we anticipated they would be, so that needed to transfer. So I think that's all useful information in terms of planning the service, but also it's really reassuring that with the model we've had, we've not caused any harm or increased risk to the population. So I'm hoping that provides provides a bit of reassurance to not just the board, but also to our stakeholders and the public and local population. So I think in short, where I think we are with this, without going through the paper line by line, is we've been out to recruitment for consultant posts. We're struggling to really generate much of a field for any of the adverts we put out. That's not unique to us. It's difficult to recruit to specialty across Wales and across the UK. So it's a very competitive market. Where we would like to go next, and what we're asking the board for today, is that we think that in order for us to put in a plan for a sustainable service that covers Carmarthenshire, we need to start scoping out what a proper engagement process would be to work up the options and the potential model over the medium to long term. And so we're asking if following today we can start that in the initial process of setting it out with a view to coming back to the board in March with a engagement process outlined and the scope of that determined. I guess the other point that I just want to add, because I think this is a consideration, not in the paper, but it's a consideration based on some of the conversation we've had today, and there is an opportunity for us to think about this over the course of the next 2 months while we're scoping what that engagement process would be, is in the context of our annual plan and our IMTP planning process, and some of the conversations we've had around how we can maximise our opportunity to recover from COVID from a planned care perspective. There may be scope for us to discuss a wider engagement, or come back with a wider engagement process around planned care, and which would incorporate critical care, because obviously one of the key things we're starting with on this is that whatever we come out with for critical care in Prince Philip is to make the current model at least sustainable, if not get back to where we were before, which would obviously be ideal. But if we can't, we want to at least maintain the current service because of our elective model. So if we weren't able to do that, it would naturally lead to conversations around how we're providing some of our cancer surgery, for example, at the moment. And we don't want, there's no threat to that at the moment. I just want to stress that, but it's just about thinking about all of the interdependencies that come when we start having that conversation with stakeholders.
Yeah, thank you. I'm sure the board would all welcome that holistic approach. Thank you. Any questions or comments on this? Anna?
Just to add to the board's deliberations on that question that Andrew's put to us, just to say that through Quality, Safety and Experience Committee, we have looked at this issue as it has been unfolding on in 2 key points to share, I suppose. One is that we were, convinced by the safety argument that was put forward as to the rationale for this operational change. Yeah. And second, that having looked at data at our December meeting in terms of how those new or temporary arrangements were going, we were satisfied that there was no deterioration in service provision and standards of care as a result. So probably just worth sharing that with the board now and highlighting it when we think about the question that Andrew's just put to us.
Thanks, Alan. That's really, really important because, as you say, we proactively took this decision for a temporary change as a board to protect patients, and the evidence is showing that we've done no harm. So that's really important going forward. Are the board happy to accept the recommendations in the paper and broaden it to a more interdependency, holistic approach once you've had a look at the scoping, whether that's feasible, and come back in March? Yeah? Okay. Thank you. And you need to go, and I think, Rodri, you need to go as well. Okay, thank you. So we'll go back to the original agenda items, and the next one is the operational update, agenda item 4.4. Andrew, that's over to you, please.
Thank you, Chair. I'm conscious that we've probably covered some items that are contained within this through the course of the meeting, so I'll try not to repeat myself on any of the issues, but there are probably just a couple of things I wanted to highlight that we've not touched on so far. I think the first point is obviously, as we know, there's a number of areas that we're being escalated to enhanced monitoring for by Welsh Government from a performance context. Whilst we've touched on a number of those in the performance report, I just wanted to advise the board that our first enhanced monitoring meeting occurred a couple of weeks ago on the 10th of January as part of our IQPD meeting with Welsh Government. As you remember, they were trying to integrate the two conversations so that it didn't add additional time to diaries and take more time of myself, exec colleagues and operational teams. I think it's fair to say that the reflection of that meeting on both sides was that we probably didn't cover some of the areas they would want to in an enhanced monitoring sense in as much depth as they wanted to in that meeting. So I've got a further touch point with Welsh Government tomorrow, and there's a few areas that we'll seek further clarification on. So it was just to advise that it's still, in terms of the interaction with Welsh Government on enhanced monitoring, it's still quite early days. We talked earlier on around some of the system pressure we've seen and the challenges we've seen in the urgent emergency care system that's impacting across health and social care. I need to record formally the fact that since just before Christmas, there have been at least 3 occasions when we've had to escalate one or more site to the highest level of escalation in our urgent emergency care escalation frameworks. That was a level 5 black business continuity level incident. That was due to the risk that we were seeing in the system at that point in terms of the volume of patients we had waiting, either awaiting admission or awaiting assessment and treatment within our departments. Pleasingly, the system response that those escalations galvanised meant that within 24 hours we de-escalated each time, which is positive because the point of the escalation framework is that it's dynamic and you do move up and down it in real time. So it was encouraging that we got that response. And there's also been, I think you touched on earlier, Chair, there's also some learning from what we've done in those periods around some of our discharge planning and our discharge coordination that we're looking to learn from and work out how we can embed that more, because I think if we could embed it more, it would probably put us in an even better position as a system. It's obviously incredibly challenged for the sites with the workforce position they've got at the moment, and so that's why again, the conversation we're having around the plan and for next year and beyond is really important in terms of that triangulation of all of those issues, because one really is the actions are as important for 2 or 3 areas of our business as they are just in terms of developing the plan. So I wanted to make sure we highlighted that. As associated with those pressures over the Christmas period, I also need to inform the board and ask retrospectively for your approval for the fact that as an executive team, we offered 2 periods of enhanced pay to cover the Christmas bank holiday weekends. They were around our acute and community nursing staff and around our administrative staff in the GP out of hours service to support the provision of services over that period. The enhanced pay conversation is always a really difficult one, it's fair to say, and for us all as an exec team, because it's something we scrutinise quite significantly, and whenever we've evaluated it, the impact or benefit in terms of supply of additional cover is often quite marginal. There's probably some more less tangible benefits in terms of the staff response to the sense that we're trying to offer further support and provide more help and cover when they're feeling most stretched. That is probably unquantifiable in that sense, but is definitely there, and it's always something, perhaps not surprisingly at the moment, but it is always a request that comes through when the services are under pressure, particularly as we get to sort of bottlenecks or pinch points, if you like, but it's a better phrase, for staffing cover through the course of the year. So I'm seeking through the report for the board to retrospectively approve the fact that we applied those 2 periods from the for the community and acute mental health inpatient wards and community services. It was from the 24th of December to the 10th of January, and for GP out of hours it was from the 25th to the 27th of December and the 1st and 2nd of January.
Okay, thanks, Andrew.
I'm just trying to there's a lot of update. I'm conscious there's a lot of information in the report. There's some, as I alluded to, there's some positive signs around our transformation regimented care programme and some of the progress we're making and some of the awards we're winning for some of the work we're doing in that space. And let me just check that I've covered what I was going to have. We talked about the industrial action earlier on. I suppose the final point I wanted to recognise was we're aware that there have been some concerns regarding the nature and extent of patient experience in the minor injuries unit at Prince Philip Hospital, and they've been highlighted by the site management team. That it is a risk that they've placed on their risk register, and we're. I know you've been there to visit them, Chair. I know there's been communication with the Vice Chair, and I know the Director of Nursing has met with the team there, and there's a programme now, a supported programme in place there for them to review and consider the front door model at Prince Philip Hospital in the context of those concerns and those safety risks that have been highlighted to make sure that they can be addressed.
Thanks, Andrew.
I'll pause there. I will check Jill doesn't want to come in with anything, but I'm happy to take any questions or anything else.
No, thank you. And in the interest of time, we've already mentioned things like ready to leave and building community capacity, but I would want to draw board members' attention to the community nursing report, which will still be doing its round in internal forums, but wanted to get grasp the opportunity of the operational update to bring it to today. I do think it's important that we do demonstrate the level of activity that is going on within our communities from those services, but also the challenges. And I think it's going to be something we have to consider around investment and development going forward as part of our strategy.
Thanks, Jill. And just to assure you, in the pre-meeting with the independent members, we want to bring the community nursing team representatives in to discuss and to go deeper into the report. And we'll decide whereabouts in the governance structure that should go, be it board or elsewhere. Ali, I know you want to come in.
Yes, thanks, Chair. I know we've spoken about industrial action a couple of times today, but there's just some updated information for board members that we haven't mentioned. We have actually got additional dates of industrial action coming up. We've got 2 days on the Monday the 6th and Tuesday the 7th of February. We're going to see multiple unions take action. So on the Monday, from a WASP perspective, the GMB, Unite and RCN members will be striking. Within the Health Board we have the RCN. And then the following day, again with WASP, we've got just Unite and RCN, but within the Health Board we've got RCN, RCM, some midwives, and also the CSP, physiotherapy. Then there's further WAST action for the 20th of February, the 6th of March, the 13th of March, which at the moment is just the GMB, but it's highly likely that Unite will join them. And we're also just paying attention to other strike action in other sectors that might impact. So, for example, teaching unions, because we know we have a significant number of staff with children in school, they are taking action on the 1st of February, the 14th of February and the 15th and 16th of March, and we're anticipating more dates.
Thank you. Thanks, Ali. So I'm going to open it up for questions, comments on the reports. Anna, I'm sorry, Judith.
Very briefly, Chair, just on the enhanced pay issue, I mean, I've no problem with supporting that retrospectively. I'm just thinking about in the event that a similar scenario crops up in the future, would you want to continue to have that sort of flexible judgment approach, or is there any value in thinking about some sort of parameters that describe the triggers for that scenario that the board could approve, and that therefore gives you the exec team sort of mandate to do that without needing to come back to us?
That's a really good question, as always, Anna, and it's one of the topics that we've certainly talked about in terms of how we would, when we've looked at it before, we've often talked about what would the triggers be. I think the challenge for us when we've tried to do that is the triggers almost become, whatever we put in, almost become too arbitrary. So we've always reverted to it's better for it to be, or we found it more comfortable to manage as an assessment of our understanding of the risk and the staffing position over a period of time. So that's how we tend to manage it. I think one of the things, obviously, one of the things that will help. There is work going on, and Lisa may want to come in on this because she'll know the detail more than me, but there is work being undertaken nationally on some kind of enhanced bank rate or payment that would be applicable across the NHS in Wales that could be deployed in these circumstances. At the moment, there isn't really a national framework for this, and what we did over Christmas was we used a local framework we've got, which is a specialist bank rate that we've traditionally only used in critical care to help cover that service, but we deployed it on a wider basis. So that national work, I think, will help provide a wider framework for us to be able to make those decisions in. But certainly as an exec team, we're thinking about how we can streamline the decision-making process, so it's, from an exec perspective, it's delegated to 2 or 3 of us to have a conversation and make a decision.
And the lessons learned? The lessons learned, you said it was negligible, the sort of the uptake, so where's that being discussed?
We've undertaken evaluations at different points over the last couple of years. It's always interesting because when you look at that information, it often shows that at a health board level, the impact is quite minimal, but in some specific localised areas, there's a bigger uptake. So sometimes some of our front door areas or some of our inpatient areas will see a greater benefit than some others. But that benefit gets lost. And of course, the challenge with an enhanced pay arrangement, which we always come back to, is if it would be wrong, we feel, and unfair to overly prescribe that on the basis of pressure and risk to a very tight group of services, because what we don't want to do is create a perverse incentive where people pull out of covering other areas to go and work in an area that's charging, offering more. So we've tried to, wherever possible, we've tried to make it, and that's why the critical care bank position is as it is, because it's a specialist service and there's a specialist bank rate for critical care if you're working through an agency or another route. So it's, as I say, it's a difficult one. I think the evaluations have never really been, certainly from an operational perspective, we've never felt they've been black and white. But I'm very conscious that on the sort of high level assessment would be the supply generated is marginal when the cost is increased. So
yeah. I know Lisa wants to comment on that and then bring in Judith, but Lisa, could you also think about whether the complexities and the learning should go to the People Committee?
Yep, so first of all, my team are doing a full evaluation after the February pay run, so some of the monies will be paid shortly. So once that's happened, the team will do that evaluation report for an appropriate committee, so half the people. In terms of the All Wales work, it's looking at a new enhanced bank offer, so it's more than just if you end up in a crisis, what will you pay? This will be about how can we attract people to work on our bank so that actually we fill more shifts much sooner than we do now, which means you don't have that last minute crisis. It stalled a little over Christmas. The group is due to reconvene shortly. I am on that group. I think there's a lot of financial modelling, so I'm sure they've either asked or will be asking for a DOF for that, because if we enhance the bank, we've got to remember all those shifts that we pay now at the rate we pay now, which will all also go up. So it's not just as simple as the shifts that we couldn't fill by any other means then being an enhanced rate. This is about them all then being at a different rate. So it is continuing, and Helen Arthur is leading that work for Welsh Government.
Okay, thank you. Judith?
Slightly different tack actually. Community nursing report, which was great. It really welcomed it and good to see it. I guess where I'm struggling a bit is to understand how many other staff groups do annual reports. Where will we see them? Have we got an idea? Because I know I've raised it in the People Committee about seeing things other than with nursing staffs around the allied health professions, clinical scientists, and it's just seeing it pop up in here. I don't mean that to sound in a negative way. I'm just struggling to see, is there a plan? That would be one question. And then my other one, which may be easier, is did Ad Astra come back online on the 9th of January?
I can take the second question quickly, and I'll look to Jill and colleagues for the first. In terms of the second question, no, it didn't. So I should have mentioned that Ad Astra continues to be, it's an ongoing issue, and it's still centred around the same challenge, which is how they can get Cardiff and Vale back online. And there's a view still nationally that until they do that, they don't want to put everybody else back onto the system and bring that back up. So that is continuing to, although we're managing it, you know, we probably shouldn't underestimate the kind of operational challenge around the additional admin time that's taking to make sure we've got a flow of patients through the system and onto the work lists of the out-of-hours GPs, so that we're and then dealing with the outcomes of those kind of conversations, so that we can pass that information back through the system as well.
Do we know if any of those people who aren't getting through and being put through turning up in ED, or is it not possible to analyse that or have the data?
I mean, I would say, I mean, over the last, I mean, it's hard to say on the basis that over the last few weeks, the system's been under increased pressure anyway, every part of the system. And there have been moments whereby, from a 111 perspective, for example, which might be the first point of triage for some of those out-of-hours calls, they've been at the point of saying that they were just going to defer to referring through to out-of-hours because they didn't have the capacity to meet the demand that was coming on them. I feel there's probably an inevitability that when it's been at its peak, there have been moments whereby we've seen people present in our services rather than await a callback or await those points. But I would need to see how we, the triangulation of that data is sometimes a little bit challenging and takes time.
And the annual report?
Yeah, on the annual report, I think a lot of services do actually provide an annual report. I guess I just took the opportunity of bringing this one. But for me, actually, it's the more important conversation is about having a regular discussion actually with services around activity and the sort of peaks and troughs of demand, and also how we manage development within services. And I don't think possibly for this service I've been doing that regularly enough. But I think this is something that's really important to our community, and I think I do want to probably not apologise for bringing it, because I do think we need to be thinking about the challenges within our communities, which has increased actually significantly as people are being cared for more in the community with a higher level of acuity. And we're going to have to think about how we develop those services, new roles and new ways of working across our communities as we progress our strategy. So it's right to ask it, Judith, and I think we probably need an internal conversation about how we take service reports in through some of our other committees and teams.
Yeah. Jill, if I can, again, we're really pleased to receive it. Would have been good to see some patient experience stories in there as well, but that's going to be taken up in the patient experience report in any event. And we want to see them more visible. So in that internal conversation, perhaps talk about how the other groups can be a bit more visible at committee level or board level. Because we all know that they do feel a little bit overlooked as well, and they are absolutely essential to our strategy.
Thank you.
You know. So thank you for that. So is everybody happy to accept the recommendation to receive the report and approve the provision of the enhanced pay rates that were applied over the Christmas period?
Chair, shall we add to that? Sorry.
Yeah.
The Chair of Quality Committee's point also about looking at the governance of the enhanced pay as well, because that we can look at how we do that as an organisation and put back to the board as well.
Yeah, thanks, Joe. That's great. So we go on now to the next item of the agenda, and if I'm right, it's 4.9, primary care contractual applications.
Thank you. So this is actually a really important report for the board today, and I am conscious, and I'll cover that a little. This basically sets out a process that we are following the termination of a GMS contract from a single-handed GP in Solva. It's our smallest practice, but saying that, it's a really important service to the population. It's a practice that struggled for a number of years since it became a single-handed practice, but the GP there has remarkably been able to continue and provide that service, and it becomes quite a local relationship really with the community as well. It's true to say that over the years, and probably I'm thinking back at least 7 or 8 years, we tried to do some work with the wider peninsula, St David's, Solva, Newport, Fishguard, and that faltered because not all practices at that point wanted to be engaged, and I think different solutions have arisen. Some of those practices in other areas have also successfully recruited. But I do think that over the last year, we're seeing things coming back now to board around services teetering, and then we get a contract termination, and we haven't got the level of strategic plan behind it that I think we need to see. So it's something certainly that I'm talking about locally with our clusters in terms of how we look at sustainability and look at local options in terms of managing that before the inevitable happens and we get a contract termination. It is important to note to the board, though, that with this contract termination, because it's a single-handed practice, we have to follow a very strict process over a 3-month period, and that period terminates on the 31st of March, so that the GP will finish at that point in time. You can see from the paper the options that we have through the Welsh Health Circular in terms of finding an alternative and provision of service, because I'm sure board members are aware that the statutory responsibility rests with the Health Board to ensure that the population have access to general medical services. So we're in that process at the moment. We did hold an initial vacant practice panel earlier in the month, and we're now in a period of engagement with the population, which will end on the 4th of February. And the paper makes reference to the fact that there was an engagement event that actually was this week, and we had 249 individuals turned up in the village hall, which is 10% actually of the population when you look at the numbers. So a significant turnout, and people are very, very passionate about local services and how, but also very constructive conversations as well about how they think about services being provided in the future. One of the key issues that was raised, and we will be bringing further reports back at the end of the period of engagement, was the fact that this GP is also a dispensing doctor, it's a dispensing practice. And regardless of the option that ultimately the board reaches in due course, that dispensing right will finish because it belongs to the GP, and that's a really important point. So that does mean that there's no pharmacy in Solva, so the issue for patients was also of great concern on Tuesday, was the issue around collecting prescriptions and all the rest of it in terms of the local area. So that's something that was a big concern. So we are going to be holding a second vacant practice panel in a couple of weeks at the end of the engagement period to consider all of the feedback that we've had from the population. And there are various ways that people can feedback, and every patient has had a letter to advise them how they can fill in questionnaires, social media, etc. And obviously all of the engagement from the event on Tuesday. And I would encourage any members of the practice population who are listening today, if you haven't fed back, you've still got an opportunity to do so for a few weeks. And then, Chair, we're going to be, we have got a recommendation here that there would be an extraordinary board, which we know is now booked on the 23rd of February. And the reason that we need to make that decision at that point in time is we will then only have 4 weeks to enact whatever the outcome is that the board reaches at that point in time. And the vacant practice panel will make a recommendation to the board in terms of all of the information that's been considered. And that panel includes members of the CHC and of the LMC, as well as the Health Board. I think one of the other things that I want to say, that as well as the provision of local services in our strategy, which fits within our wider Health Board strategy, there is the specific issue around sustainability of GMS services per se. And I've been asking at Welsh Government level now for what I'm calling the big conversation, because there's a very, very different appetite in terms of the way in which newer doctors coming through service want to respond. It wouldn't have been considered constructive to say in a public forum previously that the independent contractor model wasn't sustainable, but I think everybody recognises that it's not. And we are going to be seeing, I would suggest, in future months and years, hybrid arrangements in terms of the way in which services are provided. We know that in other parts of our community as well, we've had interest in APMS models. There are no APMS models currently in Wales, but the Nayland and Johnston conversation, as we know, there's some consideration there in terms of how the community respond. And we know here that the community are absolutely passionate about thinking, are there creative alternatives? The challenge that we will have when we reached the board decision is the fact that we're having to respond contractually within 3 months, and that doesn't offer necessarily the level of or timing to allow some of those creative opportunities always. So that will be reflected when we consider the big decisions. But regardless of the outcome, I want to assure everybody that we will be working closely with the community to respond to whatever that outcome is. And I think, you know, we talked earlier today about the need for resilient communities, the need to work with individuals about their needs and how they help themselves, but also how we respond to providing services in a different and creative way. And we also know that the development of our primary and community services over the next few years is going to be critical to the success of our hospital at the point at which we get it. So there has been some response from Welsh Government and peers across Wales that we will be having this big conversation, but I've also asked for it locally, Chair, that we meet with our communities, our LMC, our professional colleagues, GPs, and I would suggest board members as well, so that we're thinking about our appetite for different models of care that may look very different. But what we do know is that regardless of the model, we have a statutory responsibility to ensure we provide reasonable access to general medical services. But I would suggest to board members that we're going to have to be ready for very different models in the coming times. So there are recommendations here around the process that we're asking you to note. I would just want to change one word in the final recommendation here, Chair, that the extraordinary board that I'm asking for agreement on the 23rd of February is to actually discuss the recommendation of the VPP rather than the decision of the VPP, because it will be the board that makes the decision. So apologies for that slight error in that. But otherwise, I'd recommend the paper to you and the recommendations.
Thank you, Jill, and thank you for amending the recommendation. I think the issues that you raise are over and above the issue facing the primary care team and the vacant practice panel and the board in relation to Solva, and I think it's an opportune time to raise that as well. Firstly, I want to say thank you to the whole primary care team that the engagement was an empathetic, a respectful and a considered engagement this week. But the issues that you raise, and I think it's time for us as a board, as a rural covering a quarter of the landmass of Wales, which probably more managed practices than anyone else in Wales. Perhaps there's more of an urgency here than there may be at a national level at this moment in time, that we have some sort of session discussion, be it with the partners you described, Jill, or be it as a board bringing that information before us into our appetite going forward for managed practices strategically in our rural area. And as you've just said, we know that the GP population that is coming forward now at the moment, having their own private business is not necessarily an attractive option. They're coming out with massive student loans, their own mortgages. They don't want to necessarily go into another big business mortgage and all the responsibilities of a business. They also are looking for more flexibility, part-time portfolios, specialists, training, etc. And now is the time for us, rather than go from one practice to another practice to another and consider it by itself, but to look strategically at our appetite as a board for perhaps being more flexible and taking these instances into account through the lens of the strategic direction that we may decide to go on. So outside of the board, I'd like some discussion to go on how we're actually going to do that. And it also fits in with what you've presented today, Steve, with the planning objective for you, which is place-based models in one community in every of our counties. But I just wanted to say that because it accords with what you say, and I think now is the time, having gone through the last few terminations of contracts. And I think if you look at Scotland, in rural areas, that's the model that they have, whereas in the big urban areas, it's more of the 75-year-old GP practice model. Now is the time, I think, to review.
Can I say one more thing that I missed?
Yes,
it was actually to thank all of the teams that helped us on Tuesday, planning team, engagement team, communications team, and also the CHC. It was a very well-run event, and I think the community appreciated it. But I also want to recognise at this point in time also the stress for the staff in the surgery, and the sort of anxiety. Some of them were very tearful. They came to the event because they've been working in that practice for very many years, and have those strong relationships with the community. So I want to recognise that as well. Thank you.
Thanks, Jill. And, you know, if we had a more strategic conversation, we might be able to assist with that. But the CHC, before they left, wanted to pass on the thanks. They felt it was an exemplary event. Judith, and then Steve.
Yeah, I won't repeat that. I must admit, it felt like more than 280. It was one of the best attended I've ever been to, actually, with this, and the passion for the community and resourcing in the community was very evident from all the conversations I had. I suppose the only thing I wanted to add is I do think it's inappropriate that we're still dealing with this 2006 circular, and I'm just happy to raise that anyway through vice chairs, because it is just unacceptable as far as I can see, and I worry someone could challenge that because there's so much inaccuracy. And if I can just finish, and in relation to your last point, Chair, I think I would like to see us engage with our GP trainees. We've got, I can't remember how many, 70 or 80. Yep. They will have ideas for them. We need to keep them beyond the year that they're required to stay with us after training. Really talk to them, because they're our workforce of the future, about what they're looking for, because I'm pretty sure we've got vacancies, we could keep all of them. Yep. But let's have a look at, include them in this conversation.
And we have attracted, so, you know, I should say, some practices, Fishguard, for example, 4 new young GPs went in to take over that practice. And I think the benefit of working sometimes with a larger population and, you know, the commitment to that model. So we do see that. Welsh Health Circular is being updated. It's something that's been raised very many times with Welsh Government. And actually, what if this had been October, from the 1st of October, regardless of whether it's a single-handed practice or not, the time goes to 6 months instead of 3 months for the termination process.
Thanks, Jill. Steve?
Yeah, just to pick up your point, and we do need to think, I think, strategically very differently about primary care, but I think that thinking is already going on. It's emerging in many communities. I take your point that this is quite often done in the moment of crisis when a contract gets handed back. But really heartened by the response in Nayland Johnston, for example, and how we're trying to pull together some different thoughts there. What might happen in Solva, what happened with the Fishguard opportunity. What it seems to me at the moment is we've got glimpses of what the new model might look like, and it won't be a one-size-fits-all necessarily. But we do need to start sewing that together in a way that enables us. And I think it links really deeply as well to the, I know I keep talking about the digital discussion, creating single views of patients across our whole system, creates all sorts of opportunities for different types of primary care intervention for people, which may be beyond the traditional model, which in itself will have some challenges for the local population, but I think do give some big opportunities, particularly in rural areas. And in relation to 4U and your suggestion, I think it does fit really well with that. I think what's sort of interesting for me in that is we wrote 4U really in a recognition that there are communities in our local patches who haven't got the ability, the grit, the time, the space to respond in maybe the way that the Solva community have. So in some way, Solva's doing 4U. It's all about the community getting engaged. This was about trying to find those communities where maybe they would struggle with that kind of response and helping them to get to a similar position. So it says at least, so we can certainly do more than one, but in some ways I think Solva's already doing it. And I think we'll just carry on working in tandem with that local population to see what can we put together.
I agree. It's almost, I agree. We, you know, ideally that plan and objective is for communities which don't have such a big social movement, but this is perhaps, and it's about a board discussion, but this is perhaps an ideal way to us all learn how to make that happen in a community that's already further ahead. So because it's going to take a heck of a lot longer, and it's the catalyst of what's happening at the moment. So although we're going to go through the process with an outdated Welsh Health Circular, which has 4 options, but I'm sure there's flexibility for more options, if we can reasonably justify that, it kind of brings the focus on it, that for you because of this event, almost.
Yeah, that's fair.
But that's a broader conversation. So at the moment, we're looking at this particular process in relation to this particular GP surgery where the sole GP has handed in their termination. So any questions on the recommendations or no? Okay, if the board's happy to accept the recommendations subject to the amendment in the final bullet point of decision to recommendation. And can we also add another, that the executive take forward together discussion plan how we go forward with joining together, as you said, knitting together in a strategic way our vision for primary and community care.
That might take a bit of time, but yes.
Yeah, okay. I can't understand why after this packed board meeting. But I just think this is an opportunity as well. It's almost been, come to us. Yeah. But, and then you've already started the conversation, Jill, with partners anyway, haven't you?
Yes, and, Rhian and the team, working on the early sort of thoughts around a primary care strategy. I know we're talking to Lee and colleagues, but this is a very big issue for us, I think, and won't be done in a fortnight, probably.
No, but bite-sized chunks, and the board, I think there'll be members here who'd want to participate.
Thank you.
But it obviously will come back to board. Okay, thanks everybody. Next one is the long COVID service. Alison, over to you.
Okay, thanks, Chair. In the interest of time, I'll be very brief. So at a previous board meeting, we were asked to provide details specifically around source of referral, which you'll find in the paper. And also to consider whether we needed to refresh the communications. I think there was some concern that particularly in primary care may not be aware of the service that was available. So you can see that we have got a fairly good spread, apart from we've got 6 GP practices that haven't yet referred anybody in. 4 of those are actually in Mid to North Ceredigion. So we're cognizant of that. We have delayed putting out any further communications because there was some uncertainty around whether the service would be continuing to be funded by Welsh Government because it was a specific funding stream. I'm pleased to say that we've had informal confirmation in the last 3 weeks that the funding will continue. We've not yet received a funding allocation letter about that, so I'm not sure the size of that. There is a meeting tomorrow with Welsh Government and Health Board leads about the future of the service and also potentially expanding it to other service users that maybe haven't previously had access to this kind of service. So I'm thinking particularly things like ME and chronic fatigue syndrome. So hopefully when we get clarity around that, we will definitely refresh the communications about referral routes in. So happy to take any questions.
Thanks, Alison. It's a really comprehensive paper. Any questions? No, board happy to note, and just keep us updated of the relevant committee. Thank you very much. Next we go on to the aseptic project business justification case. I think it's already been to one of our committees.
Yes, it's been a lot of committees, Chair. So just really asking for approval today. People understand the context and the need for an interim solution. Without the interim solution, there is a risk that our remaining 2 facilities fail, and we would have to outsource at the tune of about 1.8 million. So this is an interim arrangement up to 2028 to 2030, when we believe an all-Wales solution should be in place by that time. But we're asking, it's had a lot of scrutiny through a lot of places.
Thanks, Jill. Board happy to approve it. Right, thank you. Next item on the agenda is the Strategic Equality Plan Annual Report. Sorry if I missed one. The renal service, excuse me. I did that on the pre-meet as well. Sorry, over to you. The dialysis tendering process, Andrew.
Okay, thanks, Chair. I know when I read the paper, so I'm hoping this is. I'll keep it short. In essence, this is a tender that is led by Swansea Bay University on our behalf for West Wales. It's involved our commissioning team, it's involved our representatives of our population and our patients, and it's coming here really just for final ratification by the board that, in relation, or is it for information? I'm trying to remember now, actually. It's for information, sorry, around that process and the fact that they're out to tender and about to order a contract, which for us is positive in that it upgrades a lot of equipment, and it's all a positive benefit to us in West Wales and our patients.
Thanks, Andrew. And this is at the Swansea Bay Board as well today. So the board's happy to accept the recommendation. Yeah, thank you very much, Andrew. Next is the Strategic Equality Plan Annual Report. That's Lisa.
Thank you. So what you've got in the pack today is the annual report, the supporting workforce information around all of the areas of equality. You also have a disability and ethnicity and a gender pay gap report. So we have a legal obligation to produce the gender pay gap report and the strategic equality annual plan. The disability and ethnicity is not a requirement at this stage. However, in the spirit of openness, we have undertaken those reports as well. This has been to our partnership forum. It's also been scrutinised in the People Committee. The next report is due to be produced at the end of March, and we are going to look at a much better way of presenting some of that workforce data, because at the minute it's very silo in terms of the categories of people in our employment or candidates. What we want to do is start to look at it through different lenses. So we are going to look at a different approach for next time, but I'm happy to take any questions.
Thanks, Lisa. Any questions? I know you're going to improve it, but it is, I find, a lot better quality than previous reports, and it comes alive more with the story. So could you thank the team for that?
Certainly.
So the board are happy to accept the recommendation and approve both reports in particular for publication. Thanks, Lisa. Next item on the agenda is the organ donation annual report. Andrew?
Yep. So this is the annual report on organ donation services within the Health Board. Again, I think the paper's relatively self-explanatory. I think it's important to note the number of patients in Aldar is relatively small, so that can materially affect some of the percentages. The SBAR provides an update in terms of where we've got to against the priorities that we set ourselves last year as a service, and I think by and large you can see that we've delivered on those. So happy to take questions.
Okay, thanks, Andrew. Any questions? No, the board's happy to approve the annual report for publication. Many thanks. Now we're going to go on to a number of reports from different committees. The first one is the Sustainable Resources Committee. Winston, do you have anything to add?
I don't have anything to add. I'll just say we met on the 20th of December. Obviously the position hasn't moved on since what we reported. Just want to draw the board's attention to some positive areas of assurance. Get towards the end of the you can see that we received positive assurance from. Just bear with me a moment. Just scroll it down.
Okay.
I think the length of the report suggests it was quite a long meeting we had in December.
Yeah.
Sorry, Winston, could you pull the microphone towards yourself? Sorry, thank you so much.
Is that any better?
Yeah, thank you.
Right. So we did receive a business case for patient-friendly observation, which we were happy to recommend for the board's consideration at this March meeting. And we received positive assurance we received was in relation to the planning objective 3E, advanced analytics, implementation of clinical and all Wales IT systems, and 6 intelligent automated robotic. So I look forward to those developments. We seem to be ahead of the game. I think it's good for the board to acknowledge that. But that's what I want to bring to the board's attention at this moment in time.
Thanks, Winston. I think we've had quite a robust look at finance today as well,
yes,
as collectively as a board, so thank you for that. Any questions on that report? No? Okay. I go on to SDoc. You've got the report before you. Maynard isn't able to be here today.
Yeah, Chair, there are 4 items that they need to raise to the board's attention. The first is a business case, which we've already considered.
Yeah.
There's attached to the paper is a South West Cancer Centre paper, which does need board approval. We discussed the health inequalities, and it's already been said earlier in the agenda, Chair. We were looking to bring that back to a future board seminar alongside the work on social model for health and the Health Improvement and Wellbeing Centre. I think, if I'm right with the Director of Planning, that's not quite ready for board approval, it will be looking more March time. So there's only one real item for board consideration, Chair.
So that's the South West Cancer Centre. Board happy to approve that? Yeah.
Check with Lee, am I right there about the other one? Yeah.
Okay.
Thanks, Chair.
Thank you. Okay, we go. In fact, it's on this. Yeah, it's in there. 7.3 is the People Committee.
Yes, so the report is self-evident, but I just wanted to pick up on a couple of things. One is to commend Lisa's team in terms of the quality of the papers that come to the committee, and that gives us lots of opportunities to be able to dig deeper, if you like, in terms of those items that are presented at the committee. And secondly, because today we've talked a lot about some of the cross-reference from one committee to another, and I know that as part and parcel of the committee of chairs, that we've raised this issue around where should things be reported, etc. So one of the things that Lisa and I will discuss is around re-looking at the agenda to see whether we are having the appropriate items on the agenda for us to be able to give assurance to the board.
Thanks, Chantal. Any questions at all? No, thank you. The report of the Health and Safety Committee, Judith.
Yes, thank you. There's reports from 2 meetings there. Nothing to specifically draw to the attention on the first one. On the second one, which is the meeting that took place earlier in January, just for the board to note that we are going to do a deep dive into violence and aggression incidents within mental health. We had a very good report about violence and aggression, but we specifically wanted to look in mental health, which seems to be at a level that is not changing. So we just have asked for more information on that.
Thanks, Judith. Any questions at all? Okay, thank you. Then we've got 7.5, the committee update reports. Any issues on any of those reports?
There are no matters for any of the reports, Chair, to raise the board's attention. However, there were a couple of areas of risk which are detailed within the report, and it does cover quite a few committees as well as our own committee board, Chair.
Okay, thanks, Jo. And then if we go on to our partnership, working in partnership, joint committees and collaboratives. Steve, is there anything you'd like to add to the report?
No, happy to take any questions.
Any questions? Okay. Thank you. The board accepts that. And the statutory partnerships update, Jill?
Yes, just to say that we had our first partnerships award ceremony in December, which was a great highlight for the partnership and for those receiving the awards. And then also to just draw board members' attention to the fact that we are going to be producing a 10-year integrated capital strategy with some resource from Welsh Government for the next 2 years to be able to develop that. So that's going to be really important, again, as part of our overall strategy, I think, within the Health Board and social care.
Excellent. Thank you, Jill. Any questions? Okay, thank you. Then we get the board annual work plan, which is there for information.
Yeah, absolutely.
Thank you. And then the date and time of the next meeting is Thursday, the 30th of March.
So, Chair, it will be the extraordinary meeting on the 23rd of February.
And where will that be?
It's going to be remote via Microsoft Teams, that one, Chair, so it won't be an in-person meeting. But the next in-person meeting will be the March meeting.
That's lovely. Thanks very much, Jo. And so that's the end of this board meeting, open board meeting. Thank you very much, everybody. And we will go straight into in-committee.